Good afternoon, Dad. Can you see us? Please unmute.
Good afternoon and good morning.
Good afternoon, sir.
Pranam, sir.
प्रणाम।
कैसे हो?
बस बहुत बढ़िया। तो सोचे कि अब आप लोग यहाँ आ रहे हैं तो फिर हम लोग पहले आप लोग सुने कैसा।
आना इसको रिकॉर्डिंग में डाल देना।
ये सर डाल दिए सर।
Thank you. Thank you. Good morning, sir. Good morning. Please have a seat.
Good afternoon, everyone. Dr. Satish here.
Good afternoon.
Pranam.
Good afternoon, DK. Dr. Gupta. Well, all well, Satish?
Pranam, sir. All well.
Fine.
Nice, thank you.
आप लोग ठीक ठाक है एकदम ना?
हम लोग को तो अब ठीक ठाक तुम ही लोग रखोगे ना?
आप भगवान अपना हम लोग सबका देखभाल करेंगे भगवान।
ये YouTube पे भी लाइव स्ट्रीम है क्या सर?
अब शायद हो जाएगा।
उसका लिंक यदि शेयर कर लेंगे तो हम लोग और भी सबको भेज देंगे सारे ग्रुप्स में।
हाँ है, इसमें भी है, या आ जाएगा। ये आनंद,
जी प्रणाम सर।
ये YouTube पर है ना?
जी जी यूट्यूब पे है सर।
अभिषेक है, ये 3 बैच होगा।
ठीक है, मैं सर ग्रुप में डाल देता हूँ, ओल्ड वाला ग्रुप में मैं डाल देता हूँ।
हाँ, यस, ठीक।
If you share the YouTube link, I can share it with the delegates here. And
तो नहीं आ रहे हैं।
Anand, just make sure that you have the program with you right at all times, and the right speaker, the right panelists are pinned. ठीक है आनंद?
ओके सर।
Again, welcome everyone. We have about just about 10 minutes to start. I'd like to welcome everyone who is present here physically at the ACU or John Smith Stadium, including our patron, Dr. Mishra.
Thank you.
Dr. Misbah, one of our panelists, Dr. Claire Barnsley, one of our panelists, Dr. Satish Shekhar, Mrs. Mishra, Sir, Dr. Singh, Dr. Anupriya, Dr. Hema. Nice to connect with you. Please make sure that you're on mute, and we can have then one person at one time. And one of the key things for this kind of hold meetings we do is for today especially, where we might expect a large online attendance as we get along the line, is to make sure that we stay on mute. Our language today would be English for all at all times. We would avoid using any other language which some people might not be able to understand very well. So I forgot to write that in the flyer or the group chat. So we just have about 10 minutes you have 10 minutes to check your IT and everything and make sure you're comfortable with everything, and then we just crack on with our arrangements. And I hope that you can see our our physical audience here. If not, then we can make some adjustments to the camera setup to make it slightly better.
सबों को प्रणाम। अग्रवाल साहब को प्रणाम। मैं दिख रहा हूँ क्या?
हाँ, गुड इवनिंग सर। आपका थोड़ा सा डार्क आ रहा है सर।
डार्क तो भैया वो बुढ़ापा में डार्क के होगा, व्हाइट कहाँ से होगा? लेकिन जो भी है दिख रहा है कि नहीं?
हाँ, दिख रहा है सर।
थैंक यू
सर। क्या am I visible? Dr. Satish here.
Yes.
वेरी मच सो।
Yeah, just crack on.
राम ठाकुर सर, आपकी आवाज नहीं आ रही है ठाकुर सर।
हाँ, आई एम हैप्पी कि कमलेश, देवीराम,
सर प्रणाम।
पीके और
अंजलि
बोकारो,
लाइट चला था।
पीके सिंह, they all have joined. Another 6-7 minutes to come. कैसा रहा? आप लोगों का खत्म हो गया क्या प्रोग्राम?
नहीं, प्रोग्राम तो चल ही रहा है, आज दोपहर तक है।
नहीं, वहाँ बिहार में। चलो ठीक है, ये भी आ गए।
Right, can I welcome one by one quickly, just to those who have joined online, and I can see who's with me here. Before we kick off, just some general housekeeping for our physical audience here. We have 7 minutes to go live and crack on with our first segment. So I can see on the screen as of now, Anand, who's our main IT support from India. We have 2 feeds from here, one which will show you the audience and one which will show you myself and the panelists. Dr. B.K. Singh, Dr. Kamlesh Tiwari, Dr. Satish Kumar, Dr. Devi Ram, Dr. Pramod Agarwal, Dr. Virmani, Dr. N.K. Singh, Dr. Sajanand. Welcome everyone. Dr. B.K. Singh, Mr. Jha, Professor Hem Shankar, Dr. Deepak Gupta. So yeah, that's very nice, and people are joining one by one. So we will be cracking on very soon. So I did send a list of questions, which was like indicative questions to people. I hope everyone's happy with it. Nothing much. Just. He has to put his camera.
Okay.
So. Somebody will have to manage the lights here. Sanjay, if you can sit on that side, then very kindly, very grateful if you can just manage the lights. And Rohan, are you managing the camera?
Yeah.
So make sure you take some long shots.
Yeah.
And some from here going around the room. Thank you. No, there's no need. I've got a high resolution microphone here. So are you able to hear Anand very clearly?
Yes, sir.
And have you sent the YouTube live feed link? Because there's lots of events happening around, so we can just send that link so that people who are not physically here can watch this program live around wherever they are. So if you send it, I can we can just, before we kick off, we have just 5 minutes, so we can then cascade it around. So please send it if it's live on YouTube now. Thank you. So in the order of the program, I would be just asking Professor Thakur, Professor Tiwari to start getting ready for their bits. Anand, is Dr. Paul, Professor Jyotirmoy Paul online? Can you check and confirm, please?
No, sir.
Right. From the panel, do we have, we don't have Dr. Divya Prakash. I can't see him here. Could someone get him a message or something so that we are going to crack on in 4 minutes? Right. Smita, you're here, right? Okay, so, and we have Dr. Mishra very kindly. So that's for the first 30 minutes bit. We might save some time, who knows? From our first session, we have Dr. Vermani, who's, you can see online. Dr. Barnsley is clearly present here. She's made early, actually. Thank you for that. Dr. Hemshankar Sharma is here, and Dr. Satish Kumar, are you logged in, sir? Thank you. So we have first session covered so far. Dr. Raj is yet to log in. He might do it later on. And then Anand, keep checking for the sessional people.
Okay, sir.
Thank you. And send the link whenever it's ready in the whole group, and then somebody will cascade it if I miss it. Right? Thank you. We'll go live in 3 minutes, and any IT issues, Anand, on your side I need to be aware of?
No, sir. No, sir. No, sir.
Good. And our volume is good enough for you to hear? Well, thank you, everyone. We are just going to start almost now. So can we make sure that the doors are closed and somebody's manning the lights, and please stay calm and quiet behind at the back. And we are just going to start this whole summit between BJMA UK Annual Congress and our colleagues from Bihar and Jharkhand in India. So a formal good morning and welcome to all of you present here in the room as well as online from India, mainly Jharkhand and Bihar. Firstly, I'm very, very grateful to all of you to have agreed to be part of this program on this Sunday afternoon in India and Sunday morning here, having taken your precious time to be with us today and discuss some contemporary, provocative, interesting topics in a format which we have been following for about I would say 6 to 7 years now. The general structure of the session is we covered the 4 cardiovascular risk factors, followed by we added the other 2 last year, which was called Hold On, which covers all the newer risk factors, including sleep deprivation, mental health, and all those things. We are not covering that today. We'll be covering mainly hypertension, overweight or obesity, dyslipidemia, and diabetes. So before we get on to the topics per se, it is just about 10:30 a.m. UK time, 3 o'clock your time. So with a big round of applause, can I ask all of you to welcome my physical audience present here, and you all are doing a fantastic job by being with us today. So let me now start by requesting, and we're doing this in association with our charity Hridayam Foundation and the Association of Physicians of India, Bihar and Jharkhand chapter. Thank you so much. Can I request, in the order of the program, Professor B.B. Thakur, who is the organizing chairman of Hridayam Foundation India, and also a physician, cardiologist, diabetologist, one of the senior most figures in India, actually, and my dad, by coincidence, present here today, to give his inaugural remarks for this unique Hold Summit. Otherwise, we've done this in October, missing you all. Thank you.
Good morning and good afternoon, dear friends. I
No,
bring.
I'm not getting the sounds.
No, I have.
Sir, am I audible?
Please stay on mute, sir.
Are you audible?
Yes,
Ashish ji, am I
Am I-
audible?
Audible, sir.
Yeah.
Audible, sir.
Am I audible?
Yes,
Yes, sir. Yes, sir.
So, friends, good morning, good afternoon. At the outset, I bring compliments to all of you from Bihar and Jharkhand, India. Honorable guest of honor, Professor Kamlesh Tiwari, Dean, Indian College of Physicians, Professor Sahjanand Prasad Singh, Registrar, Bihar Council of Medical Registration, and past President, Indian Medical Association, Professor Divya Prakash, President, Bihar and Jharkhand Medical Association, UK, Professor P.K. Agarwal, Chairman, Bihar Chapter of API, Dr. B.K. Singh, Convener, ICP, Dr. Arun Misra, Patron, BJMA, Dr. A.K. Thakur, Organizing Chairman, Chairman, Hridayam Foundation, and Facilitator of this function, Coordinator of this function, Dr. Smita Thakur, Organizing Secretary, all the Executive Committee members of BJMA, Bihar Chapter of API and ICP, and Jharkhand Chapter of API and ICP, erudite faculty from both the continents, honorable guests, dear delegates, facilitators, ladies and gentlemen. I am happy to welcome you all on my behalf and on behalf of API ICP Bihar. The Foundation, a registered charitable organization, is committed to healthcare fundamentally for those who can ill afford, that is, have-nots, and management of lifestyle diseases for the last 25 years by doing different activities like community outreach program, examination of patients, then distribution of pamphlets for the prevention of diseases, etc., and fundamentally organizing different CMEs program across the globe. Friends, I wish to share that just a year back, 8 medical students from Imperial College of London visited our center, stayed here for more than 2 weeks, participated in health checkups in headquarters for 7 days, and attended different community outreach program. The greatest point was that they stayed there in the most primitive situation, and they did not bother for heat, etc. And they stayed in different parts of Bihar. I mean, especially the North Bihar. And they not only learned clinical medicine, but they also learned culture and our healthcare system. They also attended a school program in 2 different places. The greatest point was that they attended one such whole program in Darbhanga as a student faculty. In my knowledge, first of its kind in India, along with senior faculty of repute from across the country. And I'm proud to inform you that they performed so well and they were highly appreciated. Today's program is a testimony of our commitment to learn and let others learn for better Medicare. Our theme and aim, theme of Rhythm Foundation, is to see a smile, freshness, new energy, and desire to live longer in every patient and every individual. I'm sure, dear friends who are physically present there, must be feeling nostalgic, like homecoming, and happy to interact with friends from India, especially Jharkhand and Bihar. I congratulate the scientific committee for drafting such a nice program, provocative program, interactive program, and I think we all will learn and translate it into our day-to-day practice in Medicare. I wish the Congress a great grand success. Jai BJMA, Jai API, Jai ICP, Jai Hridayam Foundation, and Jai to all the participants who are there. I bless all of you in the almost this
ये मेरे लैपटॉप में साउंड आ ही नहीं रहा है मोबाइल से जोड़ना पड़ रहा है
I request all the persons other than the speakers to please mute themselves, please. Dr. Hemshankar, please mute yourself till you are asked to unmute. So friends, with these few words, I finish and I welcome you all again and again from the core of my heart. Thank you all for asking me to welcome you all.
Thank you, sir. Thank you, Professor Thakur, for your very kind words. With this, may I please request Professor Kamlesh Tiwari, Dean, Indian College of Physicians, and having held lots of other, designations, kindly address. Thank you.
Thank you, Dr. Ashish. Thank you for inviting me on this program of Bihar and Jharkhand, which will be held at UK. Actually, I was a part of this program a few years back. I am missing that one. But at the moment, I am here in India in a meeting. So my blessings with you. And I will thank you for inviting me for this program. Thank you very much.
Thank you, Professor Tiwari, for your kind words and encouragement. I'm sure you'd be feeling that you're part of it, what you might have missed out of until now. We are very grateful for your kind presence. I don't think Professor Paul, who is the president of API, has joined you. So could I please request our very dear Dr. Sajanand Prasad Singh, ex-president, Indian Medical Association, the registrar of Bihar Council of Medical Registration, who has very kindly, out of a great accredited this meeting from Bihar. The certificate for which is going to be given to all of you physically here to kindly address this inaugural gathering. So, Dr. Sajanand, please.
Thank you very much, sir. Dr. Ashish, Exam Foundation in association with the Bihar and Jharkhand chapter of API, ICP, Bihar, and Jharkhand Medical Association UK is holding a scientific program on hold in hypertension, diabetes, and obesity on 20th of this month. So, sir, respected our Gurudev, Professor Dr. B.B. Thakur, Professor Dr. Kamlesh Tiwari, Professor B.K. Agarwal, Dr. B.K. Singh, Dr. D.P. Singh, Dr. A.K. Thakur, and ladies and gentlemen. So I am highly delighted to know that you are organizing 45th Annual Congress and Reunion of Bihar and Jharkhand Medical Association UK on 29 and 28th July 25 at Huddersfield. I am aware that the doctors from Bihar and Jharkhand have contributed significantly to the healthcare in United Kingdom. It is also learned that we are individual as well as a group have excelled in the medical research and development in UK. I take pride in the achievement of my fellow colleagues. I am sure that meeting will not only enhance the social holding among yourself and but provide an opportunity for personal interactions. My visit to United Kingdom is due to since long, unless there is any compelling circumstances to stay back. I would surely love to be with you on 29th, 25th next month. So my best wishes to you and your organizing team and the participant for successful reunion. Thank you very much, Dr. Ashish and Dr. Smita Thakur. Thank you very much. Thank you with regards.
That was a very, very encouraging piece of words, and from our core of our heart, we are very grateful that we were able to get accreditation of this unique event under yourselves after going through the formal procedures. Thank you so much again for your kind presence. Can I then request the chairman of Association of Physicians of India, Bihar chapter, Professor Dr. P.K. Agarwal from Katihar, to address this inaugural session, please. We have 18 minutes remaining, so there's plenty of time. Thank you.
Thank you, Dr. Thakur. Respected dignitaries, esteemed colleagues, dear friends. It is indeed an honor and privilege to be part of this significant event, the hope and support of global Indian medical diaspora. As chairman of the API Bihar chapter, I take immense pride in representing our vibrant fraternity from Bihar on this international platform. I would like to express my heartfelt gratitude to Dr. Ashish Thakur, the organizing chairman, and Dr. Smita Thakur, organizing secretary, for their vision and tireless efforts in bringing this unique summit to life, connecting hearts across hemisphere and addressing heart disease, obesity, lifestyle disorders, and diabetes, the true hold of our times. This summit is more than a scientific meeting. It's a bridge between continents, between generations, and between minds committed to improving healthcare. It provides an opportunity to share knowledge, align strategies, and build networks that transcend borders. India, and especially Bihar, is witnessing an alarming rise in non-communicable diseases. The roots lie not only in genetics, but in modern lifestyle transition. Through collaboration like HOLD, we aim to exchange best practices, preventive strategies, and sustainable interventions that can be adapted globally and locally. As API Bihar, we are proud to contribute to this dialogue, and we are firm of our commitment to public health, medical education, and collaborative research. Let this summit inspire partnership, spark ideas, and ultimately brings us closer to the healthier future, both in the UK and in India. Once again, I thank the organizers for this wonderful initiative and for involving API Bihar in such a prestigious forum. Jai Hind, Jai API, Jai BJM.
Thank you, sir. Thank you so much. I'm so grateful that the BJMA members here should be listening to this, that our colleagues from Bihar are saying Jai BJMA. That is a big thing. Another round of applause for the Bihar Jharkhand Medical Association, which in my personal opinion has taken a giant leap today by just this simple connection. So I'm very grateful to all of you with folded hands to have, to at least saying these two words. They mean a lot to us. Thank you so much. Dr. D.K. Singh, Chairman, API Bihar Jharkhand Chapter. Dr. D.K. Singh, sir, you're more than welcome to give your inaugural address, please. Anand, can you pin Dr. D.K. Singh, please?
Sir, you are muted, sir.
DK, you unmute yourself. DK, unmute yourself.
In the interest of time, whilst Dr. D.K. Singh sorts his IT out, can I then request Dr. B.K. Singh, convener of the API and ICP Bihar and Jharkhand Forum? That's a very important forum which runs a very active scientific exchange between doctors, junior doctors, trainees, weekly meetings, and that's a fascinating way of interaction in the medical fraternity. Dr. B.K. Singh?
Yes. Am I audible? Am I audible?
Yes. Dr. B.K. Singh, yes, you're audible. If you're,
yes.
We can't see you. Right, sir.
Yes. First of all, I must thanks the Bihar Jharkhand Medical Association and Hridayam Foundation for giving me opportunity to say something regarding this summit. As a convener of ICP Bihar Jharkhand, I welcome all the dignitaries which is present offline and online at UK and India. It's a unique program, and I always admire that the program is such a wonderfully crafted and drafted that everyone enjoyed the academics of and the time management is very, very excellent. And I wish all the success to the program, and whatever you said to the ICP of Bihar and Jharkhand chapter, I really thanks to you and welcome all on behalf of ICP Bihar. Thank you very much, Dr. B.B. Thakur sir, Dr. Ashish Thakur sir. Jai Hind, Jai Bharat, Jai ICP, Jai API. Thank you.
Thank you, sir. Thank you, Dr. B.K. Singh. I think you're doing a fantastic job along with all our colleagues. I know I'm part of that forum, and we can't replicate that in UK by any chance. So, is Dr. D.K. Singh now?
Yeah. Am I audible?
Yes, you're well audible and well visible.
Okay.
Welcome you.
So, good morning, UK, and good afternoon, India, and to everyone. It really gives me a great pleasure to join with all such dignitaries. As a faculty of UK India Hold Summit on today, 20th July, I, Dr. D.K. Singh, as a chairman of Jharkhand, extend my warm and heartfelt greetings to each and everyone. This is forum really is truly really rich with the presence of such dignitaries, with advanced scientific content, with well-planned thought to improve healthcare in deprived areas. It's really time to connect, reflect, and celebrate our journey, which has been the vision of Dr. Ashish Thakur, and it has been taken under his care. Participation of all of us, it means a great deal. I hope today will be inspiring, encouraging, memorable day for all of us. Thank you.
Thank you, sir. Thank you, Dr. Singh, for your very, very kind words and encouragement from Jharkhand. So we're so delighted to have people from both the states today. Originally, BJMA was called, is that BMGA, but now, of course, it's BJMA. So at the time of Undivided Bihar. So it's my pleasure now to move on to this side, which is the physical side of things. So I'd like to first welcome Dr. Arun Mishra, our patron BJMA. Sir, can you who is with me to give his inaugural remarks. He's a retired consultant ophthalmologist, a very senior figure, and has been a pillar of support to me personally as well, to give his inaugural remarks, sir.
Thank you. Good morning to all UK participants and good afternoon to all Indian participants. It gives me great pleasure to welcome you all, and we very much appreciate your time on a Sunday afternoon, and we very much appreciate your work that you're doing throughout the year, and we understand the economic aspects of our Bihar and Jharkhand patients, and you're doing a great job there, and it's very much appreciated by each and every one of us here. We wish that you continue such great work, and especially thank Dr. Ashish Thakur and his family who have successfully organized this function, and not only at the cost of his personal time and hard work and labor, and I'm sure it would have involved so much of his personal finance as well in traveling and organizing everything. And he couldn't have organized any better. And I thank every one of you from my heart. Thank you.
Beautiful. Thank you, sir. Thank you, sir. Thank you for your kind words. I can't thank you more for being here so early. I know you went home late last night, but I'm very grateful that you made it well in time. I'm not able to physically visualize Professor Prakash, so it's in terms of time. Can I request my great colleague, Professor Sanjay Arya, to join me on the Professor Arya is well known to the Bihar, Jharkhand community and Bihar as well. I know we are connected in a way where, you know, his dad and my dad know each other very well. And Professor Arya is a well-recognized senior, or one of the senior most physicians in Bihar. I met him just about a few months ago, physically. Anand, can you pin Professor Arya rather than Dr. D.K. Singh, please?
Thank you. Thanks, Ashish. And as everybody has said, we do welcome all our Indian colleagues this afternoon at your place and morning in Huddersfield in the United Kingdom. And it's a pleasure to see so many of you there, many of who I've had the privilege of seeing and meeting personally in Bihar and Jharkhand. And thank you, Uncle Thakur. Good to see you there. Dr. Sarjanand Singh ji, nice to see you there as well. My father sends his good wishes to you all. We had a wonderful day yesterday. We had lots of scientific discussions, how we can improve the well-being of our fellow citizens in the United Kingdom, but it can also be translated to our people from India, particularly Bihar and Jharkhand. I would like to congratulate Ashish and Smita, she sat here, for the wonderful work that they have done. It takes a lot of time, energy, effort to organize a big conference like this, attended by over 300 or 400 people. So well done, Ashish. It's good to see a fellow cardiologist doing such a great work. And we had a fantastic gala dinner last night. And he's a great singer too. So thank you so much.
And dancer.
And a good dancer too with his wife. So a big thank you to all of you from Bihar and Jharkhand. We really appreciate your time and effort this afternoon over there. And if you want to stay behind and listen to some of our deliberations, it will be our pleasure. Thank you, Ashish.
Yeah, I forgot to mention that Professor Arya is one of our BJMA members, maybe one of the only ones who might have been honored with an Order of British Empire this year.
Thank you.
That is for that we just a big round of applause. Thank you. Thank you very much.
Thank you, Ashish. And I would say that this was only possible because of the good wishes of everybody from Bihar and Jharkhand, and also I dedicate it to the BJMA, my award for OBE. So thank you.
Thank you. Right, can I, the last person in this panel is going to be Organizing Secretary, Smita. Are you happy to come over and give your remarks? And then we'll crack on with the scientific programs. So we just have we're just running to time, so no worries. Go ahead.
Respected all delegates and senior doctors from Bihar and Jharkhand and everyone joining here as part of the BJMA 2025. Really, really grateful for everyone to be given your very precious time to attend this whole summit. I hope you have a nice time, and so we are hoping so should we. Thank you so much. Much thanks.
Thank you, Smita. So with that, I think time management wise, we have 4 minutes. So if someone wants to say something, otherwise we will just crack on and save maybe time in the scientific segment. So without wasting any time, I would just crack on. And we know that this is now going to be heavily scientific. So we have a physical audience, we have an online audience, we have our expert panelists, we have our speakers. So you have the program in form of PDF on your phones, and it's now going to be non-stop for about roughly 3 hours and 15 minutes. Hopefully finishing at 1 to 1:15 at the time. You'd be shared a link to give your feedback, and then you have a physical certificate issued for the summit today. Also an online certificate for UK delegates if they want to, for UK CPD. There's a dual accredited meeting. Okay, can I then move on to the hypertension section? And Anand, can you pin the hypertension panel, which is Professor Vermani? And can I invite for the hypertension session our UK panelist to be with me here, Dr. Claire Barnsley. I'm just trying to make sure that this is not blurred. Right. Okay. So I'm sure you can see both of us. Thank you. So Dr. Barnsley is a local Wakefield senior general practitioner with lots of interests, but of course she's one of the key personalities in developing local pathways for healthcare improvement, including hypertension and everything else what you can think of. We are working in partnership to try and deliver as best possible care, both primary and secondary wise, and writing some pathways. And the journey never ends. So for this, we thought there can be no other better person than Claire to be with me today. So it's a big pleasure for you to be here. Thank you.
Thank you.
And also from the online India side, we have our, maybe I would say one and only, Dr. Anil Vermani. Can you pin him, please, as well? Welcome, sir. Dr. Vermani joining us from Jamshedpur, Jharkhand. Dr. Hemshankar Sharma, Principal of Bhagalpur Medical College. And Dr. Satish Kumar, a cardiologist and chairman of the Wellmark Hospital in Bokaro. So we have representation from UK, Jharkhand, and Bihar in this panel. So the topic, I'm going to ask Dr. Vermani. I mean, I think I've already thrown the question to you. So, and we were talking about, resistant, refractory, difficult to treat hypertension. You might just put them all together as one. And do you really think that, is it just theory, or are we doing something really? I mean, is this something which, do we just talk about it, or do we really do something?
Right.
Yes, and
yeah, thank you.
Yeah.
Can I share my slides?
Yes, just go ahead. Thank you.
Are the slides visible?
No, we can't see your slides, sir. You need to share your PowerPoint or PDF, which is. Yes, we can see them now. Thank you.
Okay.
Go ahead.
First of all, good morning, UK, and good afternoon, India. Respected Dr. B.B. Thakur, sir. At the outset, I would like to congratulate Dr. Ashish and Dr. Smita for this wonderful collaboration. My dear colleagues, both in UK and India. The topic that was actually given to me was refractory hypertension in diverse worlds. What is the difference between the guidelines to ground realities? And as Ashish very rightly said, let's take it in general as a difficult to control hypertension, though I'll be concentrating and defining refractory hypertension also. Now, the problem is both very challenging. We have not yet been able to manage simple hypertension, what to talk about resistant and refractory hypertension. And but it is not insurmountable. We can do it if we want, we can, and we will do it. Now, if you look at the Indian data, less than 15.4% of the total hypertensive groups have controlled hypertension. And that is a pitiable state. But I'm talking about uncomplicated hypertension. So when we come to others, let's look at it. What is the definition and diagnostic criteria of refractory hypertension? This is a failure to achieve blood pressure control that is less than 140 of 90 millimeters of mercury with treatment prescribed by hypertension experts at a minimum of 3 follow-up visits during at least 6 months of care, receiving 5 or more different antihypertensive medications, including clothalidone and spironolactone at maximal or maximally tolerated dose, compared to 4 drugs with resistant or 3 drugs with resistant hypertension. Now, this is not a disease in itself, but is a strong indicator of people at high risk. And you have to rule out non-adherence, drug substance abuse, and various secondary causes and white coat effect before we can label it as difficult to control hypertension, whether it's resistant, refractory, or whatever it is. And we must ensure what is called AAA, accuracy of blood pressure measurement, adherence of medications, and adequacy of antihypertensive medications. Compared to those with controlled resistant hypertension, patients with refractory hypertension have a higher prevalence of target organ damage, especially stroke and heart failure, and do not have elevated aldosterone levels. Now, diagnosing and treating refractory hypertension in India presents a unique and complex challenge that I'm sure differs substantially from those in the UK, owing to disparities in the healthcare systems, socioeconomic factors, disease epidemiology, patient behavior, and infrastructure. And I'll be trying to compare the two parts of the world and how we treat. But just to say that compared to resistant, refractory hypertension is much less, 5%, seen more in older males with normal aldosterone. They don't have obstructive sleep apnea. They're more likely to be obese, having diabetes. And because the main cause is sympathetic overdrive, they respond to sympathetic denervation. Compared to resistant hypertension, where the main cause is volume dependent because of the increased fluid volume caused by hyperaldosteronism and chronic excessive sodium or salt ingestion, and they respond to diuretics. And refractory hypertension, of course, has a higher cardiovascular risk. Now let's look at the guidelines first. The 2017, the American College of Cardiology and American Heart Association guidelines defined it as more than use of more than 5 drugs, but they basically emphasize the need for a comprehensive approach to diagnosis and treatment, including lifestyle modifications, which we often tend to ignore. Medication optimization. Most of our patients are on lesser dosages than that are recommended, and potentially device-based interventions which may not be accessible to everyone. The NICE UK rarely classify it separately. They focus on secondary hypertension workup. The European Society, similar to the American College of Cardiology, but they encourage home blood pressure monitoring, which I think is one of the easiest ways to try to look at this challenge. Now, if you compare India and UK, in India, we have limited access in rural and tier 2 cities, shortage of trained hypertension specialists. In fact, there are hardly any hypertension specialists. Whereas in UK, there is universal access to GPs and referral pathways to hypertension clinics and cardiologists. Ambulatory blood pressure monitors are not available, very difficult to get. Even in a place like Jamshedpur, there's only one center which is doing it, and whereas it is routinely used in the developed countries. The primary care in India often lacks formal training in identifying true versus pseudo-resistant hypertension, because we often don't tend to follow guidelines. In UK and others, America, there are various guidelines and there are continuing medical education programs. Patients often consult late, use unregulated alternative medicines, or they self-medicate or drop medicines because they're not able to afford it. And there are white coat and pseudo-resistance is often under-recognized because of the paucity of ambulatory blood pressure. And we hardly tell patients to go for home BP monitoring. Now, if you look at the pathophysiology, the risk factors, both for refractory and they overlap with resistant, black race, obesity, type 2 diabetes, chronic kidney disease. But patients with refractory, as I said, tend to be older, more often males. They have a persistent sympathetic drive, as it has been noted, because they have higher 24-hour urinary metanephrine levels than those with controlled resistant hypertension. They have a higher daytime and nighttime heart rates and less heart rate variability. There is arterial stiffness and endothelial dysfunction. And just 2 days back, I was reading a report that there's also some role of gut microbiota. We have preclinical data, but I think we need more data. And then, of course, there are various pharmacogenetic factors like genetic variation leading to altered drug metabolism and altered drug response with reduced effects of antihypertensives. Now, we have two-tier system in India. We have the primary healthcare centers, very ill-equipped, where doctors go in hardly 2 or 3 times a week. Then we have the tertiary care centers, the government medical colleges, where today there are numerous government medical colleges with paucity of faculty, good trained faculty. On the other hand, we have corporate hospitals where profits override patients' interest. So this is a big problem in India. And there is high non-adherence due to cost, polypharmacy, side effects, lack of awareness. In fact, now we are using a lot of generic drugs like SGLT2 inhibitors, but there are other drugs like quinolone and all, mineralocorticoid antagonists, which are very costly. And the lifestyle modifications are difficult to implement due to cultural dietary patterns. The average salt intake in India is almost 8 to 10 grams per day, whereas the recommended is to have less than 3 grams. The counseling is very poor. There is a lot of urban stress, and there is a very poor integration between the dietitians, physiotherapists, and behavioral counseling. And we often don't screen, especially in the primary care centers or in the other areas, screening for secondary causes like renal artery stenosis or primary atherosclerosis is often rarely done. Even in higher tertiary centers, I've seen they miss primary atherosclerosis. And there's a fragmented care between the GPs, cardiologists, nephrologists, and endocrinologists. It's not structured. A patient may go to this super specialist right from day one. And there's undertreatment, delay in dose escalation is common, and fixed dose combinations are underused. So less than 5% is the prevalence globally. India, we don't have any data. Higher misdiagnosis in low resource settings due to pseudo-resistance and limited detection of secondary hypertension. So if you have to look to diagnostic approach, the ideal practice to confirm adherence is to do a drug assay and look at ambulatory blood pressure monitoring. But here, we only rely on the patient's history. Whatever the patient tells us, we have to believe it. To rule out white coat hypertension, ambulatory blood pressure is not available in every place. Home blood pressure monitoring is not encouraged so frequently as it should be. And secondary causes are the diagnostic workup like renal, Doppler, endocrine workup is hardly done. Now, there are also a lot of systemic and social cultural changes, like our healthcare system is fragmented. There is largely out-of-the-pocket expenditure. The healthcare is, a lot of people cannot afford it. There is low literacy, poor understanding of chronic, any risk of any chronic disease, very poor follow-up. Once you write a medicine, the patient keeps on taking for years together. They don't even come for checkup. Poor documentation of BP logs. Ayurvedic and herbal medications are used rampantly, and they may interfere with antihypertensive effect. So what are the management strategies that I would like to suggest to put in practice? Let us prioritize adherence. Directly observed therapy in the public sector is important, like we have done for tuberculosis. Use fixed dose combinations where possible. Use low-cost substitutes like amiloride instead of eplerenone. Dietary sodium restriction education is very important, and community health worker involvement for follow-up. Now, this is an innovative and context-specific approach from hypertension protocol from the Indian Hypertension Control Initiative. This is a collaborative effort with the Ministry of Health and Family Welfare, the Indian Council of Medical Research, state governments, and WHO to improve hypertension management in India. And the aim is to reduce it by 25% in 2025. Now, the problem with this is they are going stepwise treatment, and we are recommending fixed dose combinations. So what are my recommendations to improve diagnosis and treatment in India? Widespread training of primary care physicians and protocols for resistant hypertension with government subsidies or schemes for essential ambulatory blood pressure monitoring. They should be rampantly and freely available. We must promote home blood pressure monitoring and educate patients the proper methods of how to go about for home blood pressure monitoring. Fixed dose combinations should be incorporated in the essential medicines list. National guidelines should be there for resistant refractory hypertension with tiered management, and who will be handling this case there. We must integrate lifestyle coaches and nutritionists into the primary care, where it is very important to educate our patients. And then, of course, with the AI era coming in, we must integrate digital health tools like AI-enabled BP tracking and strengthening primary care to act as gatekeepers and follow-up coordinators. Community awareness programs on salt intake, medication adherence, and BP control are very, very important. So the key messages that I want to give: refractory hypertension is rare, but clinically serious. Guidelines provide structure, but local adaptations are essential. Multidisciplinary care, cost-effective medication use, and community outreach are key. Management strategy is challenging, and beta blockers or alpha blockers may have some role to play. The developing therapies are baroreflex activation therapy, renal denervation, and continuous positive airway pressure. But we need more data for that. And future is personalized medicine, wearable BP technology, and global collaboration. Thank you for a patient hearing.
Thank you, Dr. Vemani. That was a fascinating talk. I think it covered a lot of perspectives, and which we were wanting to do actually together in collaboration between here and there. And I'd like to now invite our UK panelist, Dr. Barnsley. The question, I mean, you looked at this talk, and a lot of UK things have been covered, West, East. The question to you is pretty straightforward. That you looked at that, what do we do? What are key struggles you feel that we have here, given all the ideal things which were shown on the right side compared to the Indian context? There were lots of good things.
Absolutely, yeah.
So, but where are we in the real world? As
so obviously I'm coming as a GP working in primary care. And I would say that we see refractory.
Could you pin Dr. Barnsley, please, on the thing, Anand?
Yep.
Yeah, go ahead.
So we see refractory or difficult to treat hypertension, and it's obviously increasingly complex because we count that as patients who are on 3 or more blood pressure medications. And we're talking about hopefully having that optimal doses. We're dealing with multimorbidity, poor medication adherence, and socioeconomic factors come into play with this. One of the big challenges is therapeutic inertia. So there's a hesitation amongst clinicians to escalate despite the fact that pressure is not controlled, and that may be lack of education within the wider primary care team. We have nurse practitioners, advanced healthcare practitioners, and other clinicians working within primary care in the UK now because of the lack of GPs due to NHS underfunding. There's concerns within the team about polypharmacy, newer drugs, lack of knowledge about the side effects and the interactions. And there's also the perception that escalation won't necessarily benefit patients, particularly in the older age group. With patients, there's concern about adherence to medications. Are they actually treatment resistant, or are they just not taking their medications as we would want them to take them and as they're prescribed? So things that we do to try and combat that are using tools such as medication reviews, home blood pressure monitoring, and education to patients about their medications. We have really good access to specialist input and support locally, but that is not a national situation. We have excellent shared clinical records where we can send consultations through to the cardiologists who are really prompt with replying and give us really helpful responses. So when we are dealing with patients who are on 3, 4, 5, 6 medications, they're giving us advice about how to treat, what side effects, and if we're getting blood abnormalities on the back of that, then they are really supported with that. But nationally, that system isn't in place. So in the UK, there is inconsistency for secondary support. And the final thing, which I think is common, we have in common with India, is we need better support for lifestyle interventions. We don't have the NDT that is the ideal. We don't have dietitian input. We do have pharmacist input, and some of us have access to health coaches and healthcare workers. But as you're probably going to hear for the rest of this educational session, the weight management side of things, the lipid management side of things, it's all cardiovascular risk factors that we need to work on. We don't have that MDT there to support that. So we're working within the guidelines as best we can, but the health promotion, the lifestyle side of things is definitely sidelined.
Thank you. Thanks, Claire. I think that really sums up things in 2 sides, that there are gaps and there are opportunities. There are good things, there are things which can be improved upon. But there's a lot of work to do on both sides, I guess.
Yeah.
You know, not just Indian perspective.
Yeah.
I think the recent data showed that we have about 25% of control compared with some of the countries in the mainland Europe, which is not far away from the Indian data, which has about 15%.
Yeah.
So thank you very much for that, for your very, very valuable views. Please sit on, as I'm going to move on to Dr. Professor Hemshakar. Are you
Yes.
sir?
Yeah. Am I audible, I suppose?
Yes, you are very well audible.
Okay. Thank you.
Can you pin Professor Ramshankar in this panel, please? Now, my question is very straight to you, right? You're in next to Bhagalpur, maybe 10 kilometers away, 15 kilometers away, versus Bhagalpur town. What are your challenges you feel in terms of dealing with difficult to control blood pressure patients who you might not see very often, or who might come to see you every week, you know, from the town?
Thank you, Dr. Ashish.
I think my work has already been done by my friend Dr. Anil Veermani, who just compared you basically between the Indian context in general and the Western world representing UK or any other European countries. So you can just, if you minimize those things, you have got an access into the problems what we are facing in places like Bihar or Bhagalpur, you can say. The whole figure to me, it can be coined with API, not the Associations of Physicians of India, but A for access, affordability, and availability of what? The access of the urban residents benefits from the availability of diagnostics, robust care, approach or availability of the specialists, while the rural ones, they face workforce shortages and limited, very limited diagnostic facilities and treatment options, availability of drugs, availability of investigations. They're very, very poor in our rural setups. The second is the problem in the rural is a cost barrier also. In an urban area, the normally you are having a cash practice. Cash means you are in job, you are getting certain pays. While in rural areas, you are short of cash. That is the biggest problem over there. And if you are a small farmer, a land farmer, you are waiting for your crops to be sold in the market and then you are getting some amount of money. So that becomes a problem. This was for A. The second was patient's engagement. Engagement with the controlling physicians who are having everything in their hand. Education is a very important aspect. The communication between the doctor and the patients are absolutely very poor in places like ours. Why it is so? Because the number of the doctors and number of consultants are very few and the ratio is almost altered. And every day a senior physician like Anil Virmani or Dr. Satish, they are seeing 100 plus cases. You can imagine that how much time they can give to the patients. So it becomes really difficult. And if you are in the rural areas, in the setup, the patient, educating the patient is really becomes difficult. But that must be a routine follow-up processes, which is much better in the town area at least. Monitoring are better in some structured cities, particularly in high-profile areas. You can call corporate hospitals where the load is less, but the economic constants are much, much high. A patient who has to expend, suppose X amount of money in a place like Bhagalpur, will have to spend 5x or 10x in a corporate hospital in any big city. So this is the problem. The third I, AP, after that I is the infrastructure and policies. The infrastructure, particularly, they are devoid of insurances policy. Although the government has come up with lot many schemes like Ayushman schemes, and all the states are mostly running some of these policies, but they are not really actually in the ground realities, they're not affordable. For example, in the Ayushman schemes, you are benefited when you are inside the hospital, but outside the hospital, when you are being treated for hypertension on OPD basis, it becomes really difficult and the money has to come from your pocket. The insurance covers are really very poor in all these setups, although they are better in urban zones than in the rural zones. So that is a real problem over there. Now, what are the solutions? The solutions is an approach on the telemedicine. If the doctors, the consultants are available on telemedicine through community health workers, mobile clinics, the pharmacist-led management, and the policy-backed program by the government agencies or even by some NGOs may gap this problem inside the between the space between the rural and the urban. This is my opinion, and this can be just explored on multiple aspects. Thank you, Ashish.
Thank you, sir. We have to, that's very, very useful. I think I just want to make a comment. You know, if you were there in the last Solon Summit, we had a fantastic session on blood pressure measurement. How do we do it? Do we do it correctly? Yes, no. And we covered that whether we do it correctly in the urban hospitals, big hospitals, versus in a health checkup community camp, which we, so that issue still remains, that are we measuring blood pressure correctly? But that's a completely separate topic. Maybe we should think about that, whether are we doing that in this perspective, urban, rural, you know, is the measurement being taken properly? So that was one small comment from myself in reference to the previous summit we had. In continuity, I'm going to move on to Satish from Bokaro. Do you think that, what's your experience so far of referring someone who you have been unable to treat actually, or get to any reasonable target for something? I wouldn't say something in terms of specifying it.
Probably not. But before that, before referring, probably another challenge that I feel, and Dr. Virmani has also emphasized on that, that the first diagnosis of resistant hypertension or refractory hypertension has to be made very accurately and or correctly before you refer a patient, because most of the time the patients are coming to our clinics, we are measuring it once. uh, I don't know how many of us are measuring in both the arms, and how many when the patient gets relaxed, and the ideal situation for declaring him to be a resistant hypertension, because many of this, in fact, are having just clinic hypertension or maybe pseudo hypertensive are there. So, uh, but of course, when we do that, we tend to, and sir, Dr. Sharma sir, I don't now see 100 patients. Now I have limited. So we try to justify our, clinical approach, and uh, definitely screening for the whatever the potentially treatable or correctable hypertension must be done, has to be done, like to coagulation or renal artery stenosis, pheochromocytoma, situations like that. But even I don't know how many centers are doing therapies like renal denervation or baroreceptor activation therapy. I don't have idea. And I would like to have your opinion. What is the status in Britain on these therapies, and how successful they are? But recently, apart from the standard drugs, probably more reachable therapies have also come in the form of some medications. Like, of course, there is aldosterone antagonist, although it's still finerenone is quite non. I mean, it's quite costly here, but spironolactone or even other medications we are using. Uh, on top of that, I would like to know the opinion of Dr. Virmani also on this. SGLT2 inhibitors have come in a pharmacotherapy for such resistant hypertension in one way. And of course, recently FDA has approved, I think in 23 or so, drug like Strivio, aprocitentan, and the endothelin antagonists. So, but they're still out of our reach. And to come to your answer straight away, definitely we are not probably referring enough to a hypertensive, so-called super specialty hypertensive clinics. In fact, many of only few exist in our, government setup. Only in AIMS or maybe some medical colleges might be there, but it is still very, not available to many of us.
Right, sir. Allow me to formally close this session by thanking all of you. I'm sure that, as you rightly pointed out, that the work starts from measuring the blood pressure correctly. Am I right?
Yep.
And that's what we all need to agree to, or maybe agree to disagree to, whichever way you want to take it as. And that's the starting point. And thank you so much for your kind views.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you very much. Dr. Barnsley, can you please stay here for a second?
Can I please request our patron, Dr. Mishra, to commend our panelist physically present here for her kind time.
We are grateful for your excellent presentation and time shared on a Sunday. And we are very, very grateful for your talk. It's very enlightening. Thank you.
Thank you very much.
God bless.
Thank you.
Thank you.
Thank you, sir. Thank you, everyone. Moving on very swiftly now. Can I ask Raj to come along? Raj, are you?
Yeah, I'm just loading up. Yeah, just.
Can you hear me very well? I guess.
Yeah, I can hear you. Yeah.
Fantastic. There are some people who might not have good audio, but they need to sort their audio out at their end. Our audio is working very well. We've tested it for 2 hours between 8 and 10. So we are good from that point of view. So Raj, my question, I think I did send it to you. And do you know what your question is?
Yeah, that's right. Yeah, I do. Yeah.
So I want to take Monjaro. I can't find it. The only options I have is Ozempic or maybe something else, Ribelsis. But I'm worried that no one is helping me. And I'm so worried about my risk and all the things I'm reading about it that, it will reduce my cardiovascular risk, this risk, that risk, all over the place. And I don't have the monies actually to afford perhaps a medium term or foreseeable future. So Globacity, where do you see this? How do you see this as a UK as well as someone who practices in India? Thank you very much, Raj. Consultant.
Thanks.
Good call.
Yeah, thank you, Ashish, and thank you to Hridayan Foundation and Bihar Jharkhand Medical Association. I think this is an excellent venture to spread the knowledge about obesity and its related medical conditions. So I'm going to quickly show a few slides about the impact of what this condition is. It's a disease now. It's a disease. It's not a lifestyle issue. So it's not a one-word answer, which as colleagues and my colleagues used to give someone going to a gynecologist with PCOS, they say, go and lose weight. It's not that easy. It's just like telling a depressed person, go and cheer up. So you need to take obesity more seriously now. So what I'm going to do is I'm going to look into the prevalence of global prevalence of obesity, not just in the UK and in India, but worldwide. And I will stress on the fact that it has a significant economic impact on our healthcare economy, already stretched healthcare economy. And then I'll briefly talk about emerging therapies. So Dr. Thakur mentioned about Mounjaro and Wegovy. Yes, they're all good medications, and we're struggling to get access to it. But luckily, next year, semaglutide will become generic. So hopefully the price will come down and more people would have an opportunity to get hold of it. But the buck doesn't stop there. Mounjaro and Wegovy is only scratching the surface of obesity management. There's huge amount of work to do, and there's thousands of drugs in the pipeline, which again, I'm going to allude to. So, as I said, obesity is the most neglected and discriminated public health problem in the world, which I don't think we are paying enough attention to. It starts even in primary school. It's mostly discriminated, starting from primary school, going up the ladder. You don't get jobs. You can't even get into any college. It has a significant impact. So the discrimination is there. It's there in the movie industry. It's there in public health. So why are we not paying any attention to it? Why are we trying to turn a blind eye to it? So just to give a snapshot of the obesity prevalence, it's 650 million adults globally, but soon every 8th person in the world is going to be obese. That's how serious it is. And 39% of the adults are overweight. And a lot of my public health consultants who are friends, who are directors of public health, they come and tell me, look, the curve has flattened out. that means there's no further increase in prevalence of obesity, but that's completely wrong. What is happening is more people are becoming super obese. So it still is under the definition of obesity. And so I'm seeing more people above a body weight, body mass index of 50. So I'm seeing more super obese people now. So there's no way this curve has flattened. And there are a lot of regional hotspots. India is one of the regional hotspots. More so the south of the country, there's massive increase in obesity and diabetes. So as I said, the projected growth is 1 billion with a B, 1 billion people with obesity. It's a disease. So 1 billion people are going to have this disease by 2030. So let's come down, narrow it down to NHS. I think NHS is, again, like every other government, they're trying to firefight. And I think there's a tick box exercise within the NHS. It may be because of the cost. It costs 6.1 billion annually to obesity-related conditions, but I won't be surprised if it would cost 60 billion in the next few years because no one is paying attention. So the answer to the question which Dr. Thakur aptly asked is, I can't get hold of Mounjaro, is absolutely right. Currently, the government says anyone with the BMI of more than 40 can get Mounjaro, even that is not guaranteed. And that's, I don't know, it's a foolish arrangement. It could be cost implications, but by the time someone is 40, the horses already bolted. You got all the medical condition, including the 13 different types of cancers. So I can't understand this 40 BMI, there's no scientific evidence behind it. So if you look at the per capita impact for every person with obesity, it costs 14 pounds. Yes, it's expensive, but it's going to be more expensive very soon. Now let's come down to India. India is, again, they got the blinders. No one is interested. They're more interested in diabetes. There's pockets of places where obesity is talked about, specifically because Mounjaro now is released in the country and Wegovy is also released. So there are discussions about it, but it's going to be a major impact and India will become a sick society if we don't work on it. If you see, the economic burden is going to triple. Yes, the economy has improved, but this is going to pull the country down. So the decision makers have to really take hold of it. There's no point talking about diabetes, hypertension, heart attack, and stroke when you're missing the point. The point is obesity. When I say obesity, it also includes normal weight obesity. Now the game changers. Yes, they are game changers for now. It's not a game changer for in the next 5 years. There's no way they are game changers because I have patients who've been on this for nearly 24 months and they come and tell me, look, doctor, it's not as good as it was in the past. Those who have been on Wegovy, Ozempic, they come and tell me, look, can I move on to Mounjaro? But I know that in the next 2 years, they'll come and tell me, Mounjaro is no good, can I move to retoperidone? And there's a huge pipeline of medications. So I've just pointed out that semaglutide causes 15% weight loss, Mounjaro 22%, and then we don't use a lot of naltrexone and bupropion. Orlistat, as you all know, a lot of people don't use it, but if used properly, it does help people, but it's not as impactful as the GLP-1s. Surgery is going out of favor because of these medications, though it is very effective. But I don't subscribe to this now. Now, looking at the pipeline, I just did a screenshot, but I can tell you about 100 different molecules which are currently being researched. The latest ones are GIP, GLP, and glucagon. And there's one with the GLP and amylin. And then there are several oral GLP-1s. There's already one called Ribelsus, which is semaglutide, which is the first peptide to be used for diabetes, which is not licensed for weight management. But then there are going to be targeted therapies like gene therapy approach, microbiome modulators, and smart drugs. There's going to be weight loss patches, weight loss implants. So there's going to be a massive amount of medications coming out into the market in the next 10 years. But My take on it is none of these drugs on its own is going to work. We have to treat our patients with obesity like diabetes. In diabetes, we use metformin, gliclazide, pioglitazone, gliptin, GLP, SGLT. That is exactly how we should do in obesity. You can't have one drug. You have to use a combination of drugs like malabsorption, appetite suppressant, microbiome modulator. That's the way to go forward. If the governments across the world don't realize this, we're going to suffer. So if you see the modeling, I've just got some information. What we don't understand is by having obesity as our priority, we can cut down 70% reduction in progression of prediabetes to diabetes. And then there's a 20% reduction in heart disease, 10 to 15% reduction in obesity prevalence. And as I mentioned, there are 13 different types of cancer. We can reduce it by 20 to 30%. I was talking to one of the senior NHS advisors. He's a think tank and he works for one of the think tanks in London. And he was saying, if we could just postpone mortality by just 2 years, the country would save billions. So the problem is we are just firefighting. So it's exact simile. If you just focus on obesity for the next 5 years very seriously, we could not only save lives, but also the economy. So Dr. Ashish rightly gave me this title, red tape. That's rampant, both in India, US, and the UK. Every procedure is lengthy, and everywhere it's a tick box exercise. All these weight management programs, I don't think they're effective at all. They've been contracted to lots of providers, but I don't think they do a good job. I don't think they will have an impact on the public health at all. So that has to completely change. It may be cost related, but it's penny wise, pound foolish. The serious inequities, it's sad that the obesity impact affects the lower socioeconomic group, whereas Monjaro is freely available privately and it can be afforded only by the people who got some money. So again, this inequity is not good for the healthcare. It will bite us later. What I would really want our doctors, there are a lot of senior doctors here, is to look at why this is happening. We know that a lot of money is put into pharmaceutical industry, and that's why the pharmaceutical industry want to reap the money back. So that's understandable. But they can have, a lot of countries have got agreements with these companies to reduce the impact. And the priority should be obesity rather than any other chronic disease.
Raj, can you wrap up?
Yes, that's it. This is my last slide. As I said, we have to think differently. We have to use the newer technologies, digital therapeutics, and we have to go towards prevention. As I heard earlier on, prevention should be the key. Okay, thank you.
Thank you, Raj. I think we got the message that, it's not that easy. It is expensive. Red tape is going to carry on. And we all have to come and, follow some process before one of us could rather go on it. And if it's unregulated, then there could be potential implications, which we keep hearing about here and there. So we will stop with your bits there and now move on to our first panelist from UK, Misbah Mohammed, who's a good colleague and a senior consultant endocrinologist. Can you put us on the pin us in the panel along with Raj and also Dr. Sanjay Singh, Dr. Deviram and Sanjay Singh. So, Misbah, my question was very straight. The BMI 45 and above, how do you rationalize what is the best way? I mean, in your practice in UK.
Right. So first of all, I would like to thank Ashish for this invite and the BGMA. I would tackle this question in the way that I would treat these complex, severe obese patients in my obesity management clinic at Dewsbury. The way forward is a multidisciplinary team approach and getting a structured education program, behavioral modifications, and of course, partnering with the patient to make a program which will suit to their needs. Let me elaborate how I would go about doing that. The first thing that I would do is I would assess the person and the family member and go into the background, because I would like to know what has their journey been like? What is the reason why they are obese? Many times we tend to find out that they have had emotional insults in the past. They could have had issues of emotional deprivement or situations where they could have been aggression, loss of close family member, something which have instigated an abnormal association with the food. So that's something we need to address before we move on. Other things that we need to think about could be, for example, in case of, say, women. They have multiple pregnancies, bear more children, and every time they gain weight, and unfortunately, they fail to lose all that weight. And over a period of time, they're gaining a lot of weight. Things that we need to think about, for example, could be their physical abilities and mobility. A person could have been physically active, but one sports injury, a fall, a fracture, or change of job plans from an active to sedentary job could have changed things, and they start to gain weight. We have to not forget about medications. People could be on steroids, on antidepressants, and they could have been the cause for their weight gain. So everybody's journeys are different. So we need to look into that. Other thing that I would also like to consider is, has the person already developed any complications of obesity, like type 2 diabetes, hypertension, dyslipidemia, sleep apnea? We need to address that as well. And of course, we need to address for any other things which may be complicating the health, like smoking, alcohol, drug addiction, and things like that. Last but not the least, then we may formulate a plan, and then they join a structured education program for 3 to 6 months. This is again in partnership with the patients. Where we tell them, see, look, the most important thing.
Can you give me a call after half?
Okay. We tell them, look, the most important thing is make small changes, but make definitive changes. Consistency is the key word here. So they then get to see the multidisciplinary team members, which include a specialist dietitian, which has got interest in obesity management, a physiotherapist, a clinical psychologist. The clinical psychologist will address all the emotional eating issues, binge eating disorders. They need to be addressed, because if we don't address the root cause, then we are not going to give them a long-term solution.
So at this point in time, just a quick interruption.
Yeah.
What successes have you had? Or what are your kind of regrets? Just quick. This is very quick. In 1 minute.
There has been significant success that we have achieved, because once we have a structured program, once we tailor it to the patient's needs, once we start using pharmacology, once we start addressing all the issues together, the success rate is brilliant. We get about 35, 40%, 50% success rate that for the patients who come through our program. So that's brilliant, because people who have been doing it by themselves.
Dr. Agarwal, don't share, please. Can you stop sharing your slides, please? Thank you.
So people have been doing it individually. They would not be as successful as what we would do, because we would give them access to medications, to surgery, because bariatric surgery, again, it's not for everybody, but it's a last resort. But in the NHS, they have to come through us to be able to have access to that, to be able to access medications like Raj was talking about, the GLP-1 analogs, Monjaro and Wegovy. Of course, with a combination of all these factors, we are able to get much higher success rates.
Well, thank you. So there has been some success, which I've seen in my own cardiology clinics quite significantly, actually, people feeling better, their HbA1c, inverted commas, getting much better. So that is, we see that, personally, I would see that as a success. Not everybody can exercise.
Indeed.
There's a lot of, especially in the South Asian community, arthritic problems are early. So there's lots of things, especially as you approach 50s, 60s, it becomes a big issue.
I think that's why to have a physiotherapist on the scene is important, because they could do advise things like chair-based exercise or water-based exercise.
Well said. Thank you so much. Thanks for your views. Can I quickly move on to Dr. Devi Ram, our senior consultant physician diabetologist joining from Purnia, Bihar. Can you pin Dr. Devi Ram, please?
Thank you, Dr. Ashish.
Good afternoon, sir.
Thank you very much. At the outset, can you hear me?
Yes, my question is, welcome, sir. You know my question? I think your audio on your side might be a bit weak. So my question is GLP-1 practical experience from ground in the Bihar.
Yeah, thank you. At the outset, I wish to congratulate Dr. Ashish Thakur and his team for organizing such a unique, unparalleled, unprecedented historical summit covering 2 continents. I suppose it will be remembered for ages to come. It's also my privilege to interact with our friends and colleagues in UK from Bihar and Jharkhand. Coming to the topic, it was really very wonderful deliberation by the learned speaker, Dr. C. Rajeswaran, who had enlightened us how to face and treat obesity. Now, coming to your question, once I got it, I did explore it from many dietitians and endocrinologists who are using GLP-1 analog for the treatment of diabetes and obesity. And the overall view is that cost, availability, and side effects are major concern in Bihar. Moreover, most of diabetologists are using GLP-1 agonists in diabetes who are obese, but there are some who are using it just in obese patients. The overall view is that semaglutide oral is one which is mostly prescribed if you consider across the Bihar and with varying results. Injectables like semaglutide, liraglutide, extenamide, duoglutide are being used by many and they are found effective. It seems to me that coming years will shape the proper format for GLP analog in Bihar, particularly with the expiry of the patent. Indian pharma will be manufacturing these, which will be much cheaper and readily available. But at the same time, I wish to say,
Can I ask a very quick question? You were present at the whole summit in 2021, 2022, when Ribulsis was launched in Bihar, and we had held a debate as to which one is the winner, Ribulsis or metformin. So 3 years down the line, do you still think metformin is the one which would do the trick?
If you ask me personally, the semaglutide has got side effect in more than 25% of patients when you increase it from 7 to 14 milligram. Metformin, being a much cheaper, readily available drug, it has got its own place.
Thank you, sir. Thank you. Any other thick comments you want to make?
Yeah, I wanted to say that SGLT2 inhibitor, though it is approved for diabetes with obesity, but has been found to reduce weight even in non-diabetics. And they are readily available, and now they are very, very cheap in India. So it could be used to reduce obesity, but I'm not aware whether we are entitled to do so.
Ms. Ba, do you want to comment on that quickly?
Right, okay. SGLT2 definitely has got a role because people with obesity have got a lot of cardiovascular issues. So I don't see why we can have SGLT2 inhibitors in the list of medication which can be used to help using it, especially if they are going to be cost effective. Yes.
Right. Raj, any quick comments?
Yeah, I agree with Misbah that it could be used, but currently it's not licensed. So once we get the licensing, I'm sure we all will be able to use it.
But it does reduce weight loss. I've had some patients telling me.
Absolutely. It also reduces fat percentage on DEXA scan.
Right. Thank you very much. So moving on quickly, we have about 6 minutes remaining for this session. Dr. Sanjay Singh, Professor of Medicine in Ranchi Medical College, or RIMS, Ranchi. Is he online? Can you ping Anand?
No, sir, he's not on.
Right. Well, in that case, we can have some discussion between Misbah, Raj, and Dr. Deviram. So where do we stand in terms of, so Misbah says that there's lots of other things which work for the higher BMI segment patients, where you have psychological or clinical psychology and all sorts of things which are going along with the newer options which you add. Now, in Indian context, it is hard to store injectables at those temperatures, which need a cold chain and all that stuff. So Ribelsis is the only option, personally available. I would, there's lots of patients under Hidden Foundation on Ribel, but it's very expensive, as you know. Now that's become generic. It's now adopted differently. But as Dr. Deviram said, that the dose goes up, 14 milligrams, 6 o'clock in the morning. People wake up at 4 o'clock in summer. First thing, you need to have it without having anything else. And then you don't need to eat for 15, 20 minutes. And only then you have, and then you start to have the GI side effects, etc. Do you think it will do any good to our Indian brethren or our states in India?
I think I would take a different take on this. I would probably recommend that ICMR does invest in creating our own molecules back home in India. So molecules which will be suited to our set of population. And if they are produced locally, the cost will be much lower and much more effective. And that way, the medication will be much more easily accessible to the society. So rather than us relying on what's available now, I think we should develop our own indigenous molecules, like how other countries are doing. There's several hundreds in the pipeline. So I think we should have our own in India.
Sure. Raj, any comments on that?
Yeah, as Dr. Deviram was mentioning, it's going to become generic next year. So it should be, the cost should come down. But also there's a paper which I saw recently, which showed that you don't need to stick to the recommendation of the pharmaceutical company as far as dosing is concerned. You can go into micro dosing, and that significantly reduces the side effect. I think people should start learning this and not stick to the recommended dosing, because this particular paper was very good and it clearly showed that you don't need to start with 2.5, you can start with 1.25, and you can titrate it depending upon your needs. Yeah.
Right. So within the constraints of time, I think we need to wrap up this session, agreeing that it is possible.
Can I say one thing, Dr. Ashish?
Yes, sir.
Yeah, I totally agree with the speaker that we don't need to go to the higher doses. The lower doses might do the trick. At the same time, can I ask what's his opinion about the orlistat and other drugs used for obesity?
Anybody? Ms. Raj, go ahead.
Orlistat is good, but the only issue is the side effect of explosive diarrhea and the gastrointestinal side effects, which really put patients off. And they find that they have to be in access of the toilets facilities. Otherwise, they might have a bad accident. So that's what really puts them off. So that's why the uptake of those medication is not very high.
Thank you, sir.
Thank you.
Thank you. Thank you. With that, we will close this session. We have an advantage of 2 minutes, which is a lot. So moving on now to the next theme.
Before we do that.
Can we, sorry, if what?
Can I invite Dr. Sri Krishna Singh to please come over here and
Commend our
yoga panelist, Dr. XK Singh. Sorry, you can't hear.
Senior and past president.
Thank you, sir.
I'm surprised, delighted, and also glad that somebody has recognized my aging process. And also, all my life, I think I'm the senior member of the BJMA.
Indeed.
And one of
You're a patron,
past president, and is still patron.
So we have Dr. SK Singh, who is a patron and one of the senior most members of BJMA UK, who is felicitating our panelist, Dr. Misbah, locally, physically present here, which you might see. Right?
Thank you.
Thank you, sir. So quickly moving on now to something which might raise some more controversies. Can I ask for the lipid section, my panelist, Professor Arya, to join me, please?
Thank you.
Physically from UK. And Dr. Rajiv Agarwala, who doesn't need much introduction. He's an international speaker, runs a big charity, and in Meerut, has a big center, and you can see him in ESC, is the best place to meet him sometimes. Welcome. And our other panelist for the lipid, we have from the two states, from Bihar, we have Dr. Deepak. Are you around? From Ranchi. Deepak Gupta?
Yeah, I'm here.
Hi. Deepak from Ranchi, a consultant cardiologist, interventional basically, and Professor UC Jha, Department of Medicine, HOD from Darbhanga, not far from Muzaffarpur. So let's crack on. So, Dr. Agarwala, can you hear me? Dr. Agarwala, can you hear me? Rajiv?
Yes, I can hear you, and I should be audible and visible both.
Yes, thank you. So the question was, like statins, injectables, a lot of discussion going around LPA, patients coming to us with questions privately, actually, not on the NHS mainly, that, I'm worried about this LPA thing. Somebody said that this is causing, my LPA is high. They're having this annual company health checks and all that privately and coming to you with reports. And you're reassuring them about it's all work in progress, and LDL is the winner, which we discussed in the last whole summit, which you were part of. So let's revisit things and see, from a different perspective about how does that translate into regression of plaque, which perhaps you're going to cover in the next 10 minutes. Over to you, sir. Thank you.
I'll take around 15 minutes or so because the time slot is 4:30 to 5. I thought it would be a bit longer. So my mission is regression of atherosclerosis. I think atherosclerosis is not a new disease. It had been seen in Inca mummies, so only the pattern of the disease has changed, but the disease had been part of mankind. If you look at atherosclerosis, there are two pathways, ACS and CCS. Once we have ACS, we try to do residual risk modification and convert it to CCS. And a lot of host factors throw again ACS. So we are in the vicious circle from ACS to CCS without realizing there is an exit route, which is called elimination of atherosclerosis. So that is one very fundamental thing, that our aim when we are treating coronary artery disease or atherosclerosis is elimination of atherosclerosis. This is last year's ESC. This is a very Patrick Sarai slide and very imaginative and futuristic but realistic slide that allows that the future of atherosclerosis is pharmacological revascularization. The rate of mechanical revascularization may diminish over a period of time. So that is the thought process. As Dr. Ashish said, whatever sclerosis and intervention, reduction in LDL leads to regression of atherosclerosis. CTT meta-analysis confirms that there is incremental benefit when we do more LDL reduction. That prompted Dr. Braunwald to talk about race to the bottom. Now we are talking of LDL, which is submolar, 0.9, 0.4. And that is how we look at LDL reduction, that we have to be submolar. This is something I like, which is very common to understand and very realistic and simplistic, the grammar of atherosclerosis. We have started talking now total plaque burden, age into LDL-C multiplied, and then we can make out milligram per years. If the value is more than 5,000, then we know that the plaque burden is going to be expression of coronary event. Intravascular ultrasound is in vivo mechanism by which we can understand plaque burden, and change in plaque burden, reduction in events that is highly significant. Smoking and hypertension are two other components. This is a very recent slide, again talking what is the plaque burden which becomes significant. So if the plaque atheroma volume is less than 2.6%, you are better off than more than 2.6%. The sensitivity and specificity is around 90%. So that is a very strong determinant in vivo or by IVUS or by CT angio non-invasively. And it had been shown that 1% reduction in mean plaque atheroma volume result in 20% reduction in odds for MACE. The another part of the grammar is thin cap fibroatheroma. That these atheromas, if they have thin cap, they are more prone for rupture, which is a common sense. So if the lumen diameter is less than 4 or plaque burden is more than 70, one of the important determinants which continue to hold ground is thin fibrous cap atheroma. That means the fibrous cap is very thin. Another component of grammar is lipid core burden. So if you have higher lipid core, then these patients are more prone for coronary events. What are the vowels? Fibrous cap thickness, calcification, atheroma volume, neovascularization of plaque, and perivascular fat, which is a very, very important component. And anybody can do on a routine ultrasound on a Zoom paraexternal image that how much is the perivascular fat. 7 millimeter is cut off. If you have more than 7 millimeter, you are likely to throw more events. And there is a continuous talk between plaque and pericoronary fat. And in fact, pericoronary adipose tissue area correlates with events. And there are various modalities which talk of different ways of assessing the atheroma. I don't have time and mandate to explain all this, but I'm going to talk that how we can look at regression of atherosclerosis. I have on my own arbitrarily defined these words like Stone Age, which was Apoe Milano way back in 98, high dose reconstituted IV HDL when given in acute coronary syndrome, and it was realized at 25 weeks there is reduction in plaque, which had been shown by this. So that was an insight long back that probably even in acute coronary syndrome, we can reduce plaque in short term. But unfortunately, Milano pilot project failed that when this was given on top of statin, it did not work. So this concept died out at that point of time. Then came the Bronze Age. We looked at statins as the savior of mankind. This was a trial called Reversal, taking atorvastatin 80 with pravastatin 40, and it did not absolutely regress atherosclerosis, but in comparison to progression, it was significant. And look at the values achieved, 80. The LDL achieved was 80, which is quite high. Then came the Reversal asteroid trial, and rosuvastatin was talked as a gorilla statin, and we brought from 80 to 60, and now again you see that plaque atheroma volume for the entire vessel was reduced, atheroma volume in the most diseased segment was reduced, and total atheroma volume was reduced. So we started aiming, assuming, and hoping for regression of atherosclerosis with these molecules. Regression with high-intensity statin, this is not a head-on study, but this shows that regression is possible. When combined with ezetimibe, again, the regression is more. And simplifying one concept, it is not agent specificity, it is the LDL achieved which is result and correlates with regression. Fibrous cap atheroma, again, it was shown that this fibrous cap atheroma, which is a protective mechanism, increases by aggressive lipid lowering. Don't get confused that I'm talking with the statin. I'm using the word again, lipid lowering, which is not agent specific. They also reduce epicardial fat, which is very important in acute coronary syndrome and arrhythmiogenesis. This is a meta-analysis again in favor of statin and epicardial fat. This is a concept of neovascularization, which is also very important for crosstalk between pericoronary adipose tissue and plaque, and it can result in plaque hemorrhage from outside, and that can also increase obstruction. And statins have been shown to reduce neovascularization, which is once again one of the vowels and grammar of atherosclerosis. So looking at the progression of coronary atherosclerosis and plaque composition, the plaque atheroma volume keeps on decreasing as the LDL value goes down, and fibrous cap thickness keeps on increasing as the LDL value goes down as low as 20. And this is just a description of that because these statins can bring down to 60 only. And this is the linear relationship. Most of the guidelines stop at 50, while the atherosclerosis starts regressing after 50. That is the biggest mismatch with the guidelines and the reality.
Yes, sir.
Comes the Iron Age. Glagov trial again showed that Glagov evolocumab results in aggressive reduction in atherosclerosis. Is more important is even if population which is less than 70, if you give evolocumab, 81% patient showed regression of atherosclerosis, while we were in earlier guidelines happy with 70. Americans are still stuck up with 70. So Glagov also showed there is a life or there is science beyond 55 because the regression starts from there. This Huygens is a different molecule. Evolocumab showed that there is regression. This is the regression in LDL, shows the increase in fibrous thickness, shows decrease in inflammatory activity. And this is what it shows, that the fibrous cap is increased, lipid core is decreased, neovascularization is reduced, so plaque becomes stable. Then came the alirocumab, Pacman-AMI, the same molecule which was used in Odyssey, and again showed, they talked of maximum lipid core burden index, showed that alirocumab decreases it more. Primary endpoint, percentage change in atheroma volume, maximum lipid core burden index, and the change in fibrous cap all go in favor of stable plaque. These are the normograms which show lower is better and mark the life of regression starts after 50. And this is the LDL achieved in this trial. Pacman-AMI 23 in Odyssey, they stopped at 50. They realized that is a trial defect. Odyssey, they stopped at 50 and reduced the dose. But in Pacman-AMI, they were very happy with as low as 23. And this is the loss of lipid core burden. You can see in just a short while in patients who are alirocumab and statin making the plaque stable. And that is why we talked there that the early bird catches the worm. And we have started talking extensive lipid lowering in acute coronary syndrome. Architect is another study which is published in homozygous hypercholesteremia and showed that patients who were not having expression of the disease, 87% when it started early, they showed regression of the disease. So this is the nutshell, that the plaque is significantly regressed. And these are the curve. This is the placebo change in fibrous cap thickness. As the LDL level goes down, the plaque thickness increases and make the plaque more stable. This is change in plaque and lipid component, since they are not add-on, but the direction is same. So a vulnerable plaque is make a stable plaque, and stable plaque is made a smaller plaque by regressing the atherosclerosis. And you can show the curve keeps on going down So there is no plateauing effect. It keeps on going down, and we have now started talking less than 0.5. That means 20 milligram of LDL. This is again a very good trial that if you reduce pericoronary adipose tissue, even the event reduction is more. LDL level 10, less than 10 are safe. The side effect profile is more or less same. And there is a story of EPA. Again, when you give EPA, there is plaque being positively modified. That is again a statistics to carry home, that in EPA group, they showed a favorable reduction in all the parameters, making the plaque stable. And this is the best expression that this is the evaporate study is the first alignment marriage of clinical trials reduce it, and imaging evaporate justifying that EPA is a modifier of plaque. There are other drugs, SGLT2 inhibitors, which can favorably affect the plaque, like colchicine can affect the plaque, mineralocorticoid can affect the plaque. So how we synthesize? The basic message is LDL should be as low as possible, maybe as low as 36, less than 30. There is a delay. If you delay it, the plaque gets calcified, and these patients will not regress. So younger the patient, roughly less than 50 years of age, like majority of our patients are, they are the appropriate candidate to aim for regression of plaque. And as you regress the plaque, events keeps on decreasing. So ladies and gentlemen, plaque reduction goes hand in hand with event reduction. So from LDL reduction, we have gone to LDL eradication, and the arithmetics is very simple. Dr. Brown and Goldstein showed that as low as 25 is good. And now I often say we should stop using the word lipid lowering therapy. We should call it plaque therapy, because that connects clinicians that they are dealing with the plaque, like we say anti-tubercular therapy, like we say anti-cholera therapy, like we say anti-HIV therapy. So we have to connect clinicians to plaque rather than lipids. Plaque, our aim is plaque. And if you go for aggressive reduction, we can reduce the plaque. The good thing is, unlike any other disease, unlike HbA1c, whatever way we reduce LDL, it means the same. So there is no agent specificity. So what we have learned so far is that secondary prevention, history, we are we are just finishing. And this is a recent trial which showed by this is a review article in Circulation. Dr. Fatima and Amit Khera showed that in high-risk population like South Asian and young Indians, a shared decision-making for LDL less than 10 is also a realistic aim. And you may bite a pound of atherosclerosis in these patients like Shakespeare described in Merchant of Venice. Our guideline, on which I am also a part, have talked about as low as 30. I think if you aim for regression, which there is enough evidence, LDL of 10 and 20 in retreat should be a dream in every young South Asian patient. If you want to live 100 years, the only suggestion is hit hard on LDL. Can we cure atherosclerosis? I think in times to come, in our lifetime, we may largely cure atherosclerosis if it is hit hard. Do not forget the essential life, because the foundation of drug therapy depends upon these essential life. And do not forget sleep and psychosocial health beyond the conventional risk factors. This is how we can delay the normal aging by positive influences. Cardiac rehabilitation should be the foundation of each drug therapy. I'll end up by showing a Japanese legend saying, if you get on the wrong train, get off the nearest station, the longer it takes you to get off, the more expensive the return trip will be. So ladies and gentlemen, do not depend on MACE. Aim for reduction of atherosclerosis. There is enough visual as well as clinical evidence that reducing plaque atheroma volume results in MACE and regression of atherosclerosis. After all, we are not artery cleaners, we are artery healers. Thank you very much.
Thank you. Thank you. That was scintillating as you know, as usual, Rajiv. And that nicely brings me to the question which I thought I'd ask Sanjay, that there's been so much of gradual lowering of LDL guidelines, which as cardiologists we are bombarded with in terms of learning as well as application to clinical practice. And then there is this nice guidance, and this is the core parameters: primary care, secondary care. Where do we draw the line? I mean, yeah, we try and keep emphasizing that let's optimize as much as possible. However, we can't win. What's your take on this?
Thanks, Ashish, and thank you, Rajiv, for that amazing resume of how can we make our plaque regress and how can we halt the progression of plaque. And as Claire, you rightly said about hypertension, and then we had it about obesity. I think we should be on the same page in terms of primary care and secondary care. I totally believe what Rajiv has said, and I'm sure, Ashish, you believe that too, that the lower the better. And the few quotes, if I may take from Rajiv, because that's so important. One is you talked about pharmacological revascularization, and that's absolutely right. Everybody thinks that by putting in stents, you're going to protect another event, or you're going to protect somebody from dying due to coronary event. I think more important is the pharmacological revascularization, as Rajiv, you very rightly said. And in terms of LDL reduction, from LDL reduction to LDL eradication, I like that phrase. Number two, you talked about, and this is also, Ashish is absolutely right, is that we need to look at total plaque burden. And we now got facilities for CT coronary angiogram. We got facilities in our own cath lab for IVUS, and you can calculate the total plaque burden. And if you know the total plaque burden, you will be able to treat that and regress that plaque using pharmacological measures, as Dr. Agrawal has just talked about. And I agree with you as well. Early bird catches the worm, right? The sooner you can do this, the better. And I always say that if you are in a Western world, and I think it holds true for India as well, Ashish, that I think statins should be in the tap water, Claire, right? We should have statins circulating in the tap waters of the United Kingdom, where the incidence and prevalence of coronary artery disease is so high. And then the final thought on that would be that you talked about lower the better, and I mentioned that earlier. And I don't know whether there is a target, Rajiv, of LDL cholesterol. Once you've hit the LDL cholesterol using high-dose statins or PCSK9 inhibitors, I think that's where you should stop. If you become too aggressive, you make the person and the patient very anxious, and that doesn't help the situation either. So these are my thoughts. Yes, I totally agree. Let's not talk about total cholesterol anymore.
Yeah.
We must not forget, however, the HDL cholesterol, because we know higher the HDL, the better the risk profile. But let's now talk about how low can we go through our measures with LDL cholesterol reduction. And just final thought on I say to people is a glass of red wine. That's the excuse I give to my wife when I have my glass of red wine 5 nights a week. There is ample evidence to show that does help in LDL cholesterol reduction. And obviously meditation and stress management is some lifestyle thing that we shouldn't forget. Thank you.
Thank you. So holistic approach, lower the better. The most recent guidance, which came pretty much very recently, that get it as low as possible. So
yeah,
but
don't stress the patient.
Exactly. That's the psychological side of things. Which
indeed,
perhaps. So
yeah.
Rajiv, do you agree? And while you think about it, I'll move on to Deepak from Ranchi. Can we bring Deepak, please?
Yeah.
Hi, Deepak. Welcome. See you after a long time, actually. So, Deepak, it's come at the right time. So what's your strategy as a hardcore interventional cardiologist practicing in Jharkhand? treating almost, lots of ACS, CCS every day. How do you manage the burden of LDL reduction, or what we would now call as, of course, plaque burden or atherosclerosis?
Yeah, plaque atherosclerosis reversal is a term, and better to say that is a reversal of natural history of atherosclerosis. The atherosclerosis life cycle is a dynamic one, and basically reduction of this plaque burden by so many pharmacological therapy, we basically reduce the plaque burden and plaque stability, and it is a natural history of atherosclerosis which we reverse basically. And it is really true that lower is better. And in spite of having so many patients which had underwent the angioplasty and stent, even in those patients, we need to a careful reduction of the LDL at the lower level. Basically, when you have a more stent, more lesion, when you see in the angiogram, the multiple lesion, we are ready to give on a high intensity lipid therapy or even the PCSK inhibitor in those patients. And I think I'm now going to answer your question. Is there any patient with the age of 80 having a stent, and he asked whether he should continue the statin or not? So I think the high intensity lipid therapy should not be denied to the patient on the basis of old age only. Although the older age are underrepresented in the previous trial, but still the recent trial has shown that few trials have shown that even the total mortalities in those patients having the more than 80-year age, we have a 5-year mortality reduction. Having the acute MI patient who underwent in stent at the age of 80, you can give a high dose statin, and that has shown that reduced total mortality. I think in future, Dr. Rajiv Agarwal has shown the future of 1940 when only the pharmaceutical treatment will be available in the best way. Thank you.
Thank you, Deepak. So, despite if you take the ACS population apart in the elderly age group, what about the chronic coronary cohort?
Age group?
How would you normally go in your practice in terms of LDL, or how low would you go? How high in terms of medication, and how low in terms of LDL?
Yeah, we'll try to give 40 milligram the rosuvastatin at the time of presentation of the ACS, either acute MI or non-ST elevation, whatever this. But we give 40 milligram of the rosuvastatin and continue it for 3 months, and then we see the LDL cholesterol level, and accordingly we decrease the dose, or we may need to add some azitamib or maybe bempedoic acid. And in some patients, we have also started to giving the PCSK inhibitor. Those patients when they were not able to decrease the LDL level less than around 30. So we want to keep the LDL in every patient who has underwent ACS treatment and followed by stenting, the LDL level around 30 to 50.
Thank you so much. Last question to Rajiv, maybe just for all of us together to wrap this session up in 2 minutes. Rosuvastatin, atorvastatin. Now that debate continues as to do we have an agreement or consensus of any kind? My preference is rosuvastatin, to be honest, personally. However, I'll leave it to the panelists.
So I'll just summarize empagliflozin or dapagliflozin.
Right.
For me, it doesn't matter. What I showed you, none of the discussion is agent specific. It is the level of LDL you achieve. So whatever you are using, achieve LDL. And I'll say, I go for moderate intensity statin, if you permit me to use the word. 40 milligram of atorva and 20 milligram of rosuvastatin, invariably always with ezetimibe. I do not start. Majority of the guidelines are high intensity statin, but most of the experts feel we should use ezetimibe as step 1 because there is an incremental LDL reduction. So what is the standard is 20 milligram of rosuvastatin, ezetimibe, 40 milligram of rosuvastatin, ezetimibe, 40 or 80 of atorva and ezetimibe. They go together. Instead of 3 months, what Dr. Deepak said, the lie consensus statement says 95% of the LDL reduction you achieve in 2 weeks. So we mandate it to be rechecked after 2 weeks. 3 months is a lot of loss of time. Check it at 2 weeks. If you're not there, add bempedoic acid. Another 2 weeks, see where you are. Within a month, you know there is a school of thought coming in acute coronary syndrome in Western world, starting in inclisiran and day 1. So it depends upon your aggression, and I am not agent specific. Any agent, what matters to me is LDL.
That's perfect. And that's what perhaps I thought, rather than focusing on the dose response curve of all these different agents, perhaps what we want bespoke, and that what you meant, perhaps more like concierge cardiology, where you could see the patient much more, follow them up much more, which could be practically difficult in a setting like NHS, where we have gaps in patient follow-ups, their tests, and that needs a concerted approach. So last comment from Professor Arya, and then we'll wrap up the session.
Thanks, Ashish. And Dr. Agrawal, your topic was myths about atherosclerosis. And I just thought I'll try to simplify some of the myths regarding coronary intervention. And I see that Rajiv as an intervention, Deepak as an interventional cardiologist is there. And there are 2 myths that we need to be very mindful about. One is everybody thinks that PCI, putting a stent, is absolutely the right thing to do. But I do want to let people know here in the audience here and in India, my belief is that intervention should be guided by symptoms, unless you got left main stem disease. And if you do not have symptoms, and irrespective of how much is the plaque burden, putting in stents is not the right thing to do. So be guided by symptoms. If your patient is getting angina, which is not controlled by anti-anginal, yes, stents is important. Number 2 is people think that, oh, if I've got very tight narrowing in my arteries, I'm more likely to have a heart attack. And it's interesting, we know that, don't we? That actually 70% of the heart attack occurs in arteries which has got mild to moderate plaque, not severe stenosis. That's only 15 to 30%. So please don't think that putting stents, because somebody's got narrowed arteries of 80, 90% and is asymptomatic, putting a stent is A, going to make me live long, or B, is going to prevent me from having a heart attack. And as Dr. Agrawal very rightly said, let's talk about pharmacological revascularization rather than interventional. And it's sad that I'm talking about that being us as interventional cardiologists ourselves, right. But that's what I wanted to emphasize. The myth.
Dr. Ashish, I'll just take 10 seconds and summarize. Atherosclerosis is not a mechanical disease. It is a metabolic disease.
Indeed. Thank you.
You're absolutely right, correct. And I think we'll wrap this up.
That is all I wanted.
By just taking some summary points which people might want to read about ischemia study. It was the largest study which disproved lots of things and paved the way, for lots of things. So that's something which take-home messages. There's a lot to talk about it, but not enough time to cover. But that gave us some real insights into what we should be doing rightly and what we should not be doing. So ischemia study for you guys, who want to just see what we've been talking about in terms of revasc, putting stents in, etc., etc. Even ischemia, diabetes, CKD, lots of cohorts of it. Thank you very much, everyone. May I please request
Dr. Barnsley, please come and comment our UK panelists.
Our panelist, Professor Arya, please present here physically. With that, we'll come to the end of the lipids. And thanks, I'm very grateful to Rajiv and Deepak for their valuable comments. We will see again.
Thank you. I am honored.
And our next summit will be in the autumn, to which we'll invite all the panelists who are physically present here, because we'll be seeking feedback, which will have their contact details. Thank you so much.
Thank you.
Thank you, Sanjay.
Thank you.
And thank you.
Right, for the last one, diabetes, can I invite our full panel? So we have Professor Viswanathan. Are you logged in, sir?
Yeah, I am here, Ashish.
Right. So, Professor Nathan doesn't need introduction. Are you in Tirupati, if I'm right?
I'm in Tirumala.
Yeah. So I had a message that he might struggle because of the darshan time and all, but he's kind enough to give his time to join from there. It's one of the most famous temples in India for Claire's information. And Professor Vishwanathan, and then I've got my panelists from UK, Smita. Do you want to join, please? And our Bihar and Jharkhand panelists. Amit, are you around? Amit, Amit Das? No? NK Singh. I could see his name. Yeah. Hello.
I'm
Hi.
here. Yeah, I'm here. Yeah, I thought.
So let's crack on. Professor Viswanathan, can I just ask you yeah, you had the question, didn't you? Did you read this?
Yeah, but I'll make a 5-minute presentation.
Yeah. So can you pin Professor Viswanathan, who's one of the most famous diabetologists? He's the president of the Diabetic Foot Society, I guess, which is based, is a global organization based in Belgium. And there's lots of work and is on board with us for most of the meetings. Over to you, sir. Your question was elderly diabetic, fluctuant levels, insulin, can't afford CGM. Of course, as we know, in the Indian context, how would you go about managing them?
Can I
And then talk.
share option? I can't find it. Some other talk is coming.
I think, sir, share option is there, sir. Yeah.
Yeah, the laptop.
So, Ashish, I would like to tell that Dr. Vijay Viswanathan is also the president of the biggest diabetic association in the world, that is RSDI, Research Society for Study in Diabetes.
Yeah. Thank you. That's why I said he doesn't need introduction.
Yeah.
So, thank you. Welcome, sir.
Yeah, 1 minute, 1 minute. I'm just getting my slides. Dr. N.K. Singh is our vice the executive committee member, and Anil Virmani is also Dr. Anil Virmani is also an executive committee member. I welcome both of you to this conference.
Yeah, that's fine, sir.
Can you see it?
Yes, sir.
So I think the two problems in elderly people is the.
Sir, can you start the slide show, sir?
Can you see now, Dr. Singh?
No, sir. So you have to go, sir, a bit here. I think animation, then you will get the slideshow, sir. See above, sir.
Now?
No, sir. So I think even you can do it from the below, but yeah, sir. View is there, sir. Just come a bit beside the view.
If you go to view and see presenter view, you might be able to just bring them up.
Simple without slides. The three problems are the falls, hypoglycemia prevention, which is worldwide, whether it's United Kingdom or in India, and we have to. It's showing screen sharing. You are screen sharing. I don't know why it's not coming. But I think it's important to prevent falls in the elderly. That's what we were worried about. So people above 70 are considered elderly. People not above 60, but above 70 are considered elderly. So you have to be careful. There can be Parkinson's disease, there can be dementia, there can be Alzheimer's disease, there can be a whole lot of problems in the in the elderly population. So which are drugs which you have to avoid? You have to look at the EGFR, serum creatinine, and decide on the blood sugar management of elderly people. And I think you have to prevent falls. You can prevent hypoglycemia in the elderly people. Hypoglycemia is most often caused by insulin therapy, but insulin is the safest bet in the elderly population, not sulfonylureas, not metformin because the EGFR is very low in some cases. So not metformin, not sulfonylureas, it's insulin. The long-acting insulin, you must be careful in the elderly people to prevent hypoglycemia, and also in the prevent the falls in the falls. I mean, falling down due to age-related problems should be avoided. So hypoglycemia should be avoided in people who are elderly above 70, and you should prevent. You should check out the blood sugar most often. And CGM is going to be talked by NK Singh, I think, or by Anil Virmani. I saw in the program. CGM is useful. There's a power cut in the hotel. I'm in a hotel. There's a power cut. Yeah, it's come on now. So I think CGM is most useful in elderly people with diabetes because of hypoglycemia in the night. You can't ask the person he'll have prostate enlargement. You can ask him to get up at 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock every hour and check his blood sugar. So CGM is useful in such individuals to rule out Somogyi phenomenon. So where there's a dip in blood sugar and then there's a rise in blood sugar. So if you look at only the fasting blood sugar, you will be mistaken in the elderly population. So in the elderly population, you must avoid hypoglycemia. You should avoid repeated falls, and you should be very, very careful in people above 70. The targets, keep it at 7.5 HbA1c. Don't aim for 6.5 in the elderly, because it's very, very important to tell the target. And the blood sugar can be 10% above what you say for a 35-year-old person. It can be 120, 130 fasting. Nothing is going to happen. If he's 70 plus and if his fasting blood sugar is 130, nothing is going to happen. So I think that brings me to the end of the talk. I had only some 10 slides to present the hypoglycemia prevention, falls prevention, falling down, which is common to all elderly people. I'd like to thank Dr. Ashish Thakur and Dr. Bibi Thakur for this opportunity every year to come up and present before you. Thank you very much.
Thank you, sir. Thank you. I think in your own style, you've given us the messages as you always give us. And in this particular context, the take-home messages which we could take was prevention of falls, prevention of hypoglycemia, and also ensuring that we are not aggressive, chasing the HbA1c as a target, and keep it around 7 to 7.5. And those three, if we can handle those three properly, then we could address the elderly diabetics better than we might, besides being too aggressive or not doing the right things in the right way. Thank you so much. So that links into and the role of CGM, of course, if it's available. So that links to the question to Smitha, that what are the barriers? I mean, why do you think it transforms lives? My patients tell me that, they're privately funding themselves. It's costly, but still, those who can afford it, at least here, even in India, to be honest, Lexicon, freestyle, all that stuff. Cost is same exactly here and India. So, and it's transformed lives. So what's the barrier as a frontline GP with a diabetic lead in your patch? What issues do you see, and why do you think we are not able to help everyone?
Thank you for giving me this opportunity. And thank you, Dr. Vishwanathan. Always very, very enriching to hear you talk. So in the UK, we are facing a national diabetes crisis with over 4 million people living with type 2 diabetes. And yet, one of the most powerful self-management tool, which is the CGM, is largely denied to them by the National Health Service. This isn't a missed opportunity. This is like a false economy that we would say. NICE just limits to them to all type 1 diabetics and some of the type 2 who are high risks or who have hypo unawareness, and those who are pregnant. The rationale here is not any lack of benefit. It's mainly because of cost effectiveness. But this is just based on the outdated assumptions that type 2 diabetes they have stable glucose and finger pricks and few months HbA1c every few months is enough. But this needs to change because there are over 10 billion spent by the NHS on treating the complications like amputations, dialysis, stroke, etc. So, and we know that investing in CGM for type 2s can delay the need for the insulin, empower the self-management, and prevent the costly downstream care. And this isn't a luxury tech, it is preventive medicine, and it is much cheaper than amputation. We need updated NICE guidelines, and we need piloting across various hospital trusts. Above all, we need to trust the patients and give them the tools and let them rise to the challenge. CGM can transform lives, and we have to stop here. We need to stop rationing them and make it available to all diabetics.
Does that cover everyone, do you think, or certain degree of diabetics where you're worried about? Or
I think we have a little bit of flexibility in primary care in terms of if they have like very fluctuating sugar levels and something to do with dexterity, like severe osteoarthritis, rheumatoid arthritis, where they will struggle with finger pricks. We have some leeway there to give them CGM, but it is very, very heavily controlled by the ICB and medicine management.
Is there a postcode lottery?
It is much easily available and should be in more deprived area, but which is not. And Ms. Swa will agree with me.
Ms. Bao, you're around.
I totally agree.
You want to give any quick comment quickly about this?
So I would say yes, CGM would be a great benefit, especially in the elderly and elderly who are on insulin. So if NICE is able to come with some guidance to support this view, that will significantly benefit all those admissions with falls and all those confused states and things. I think that will be a lot of savings in long term.
So I'll just give you a very quick. Last week, I had a patient who had a heart attack in Dubai 2 weeks ago, and he was put on CGM from that point onwards, and within 2 or 3 weeks, his metabolic profile had already changed. Of course, HbA1c, etc., was to be measured, but he was in a much settled state mentally, otherwise as well. So that was the theme which I wanted to bring, and there will be several examples everyone will be having in their personal practice and clinical practice, etc. So Claire, do you want to make any point about this? We have got a couple of minutes just to wrap up, and then have NK Singh.
I just feel it's a shame that within the National Health Service we have health inequality so much in this country. We are a first world country, and right. It shouldn't exist. The funding should be there. I am medical politics and chair of the LNC Wakefield is one of my roles. So we have this set up conversation with commissioners all the time.
Sure.
So areas that we do try and push for.
Yeah, and imagine India where it's, it's just, if you want to buy it, buy it. If not, then you can't have it, full stop. So it's two sides of the world, completely different. But working towards common themes is always a challenge. Thank you. That brings me to Dr. N.K. Singh, I think he needs a bit of introduction because he's the only guy, perhaps, who runs the world's largest CME program. How many members do you have, Dr. Singh?
This time, sir, 9,000 on the WhatsApp group.
So 9,000 members,
Yeah.
world's largest CME program, runs 24/7. And I'm fortunate to be part of it for some time. And anytime, 24/7, anyone can put up a clinical question or query. Any trial which is published gets, so you need to experience it. And there is an article he's contributed to in the souvenir, if you got one, and you can read about it. And if you want to join it, feel free to contact through channels. But besides that, Dr. Singh is a very famous physician, endocrinologist, cardiologist, rheumatologist, all in one from the city of Dhanbad. He's joining us from today in Jharkhand state, not far from Dr. Virmani. So, Dr. Singh, my question, ward management. Now let's move from outpatient to inpatient, just for the sake of discussion on the topic.
Yeah.
How do you handle this shift of someone in the hospital, maybe knee surgery, knee replacement? I've had some really interesting experiences around the surges in glucose, which happen around those periods of time when people go in for procedures, elderly people, comorbid, managing them. What are the key challenges you think, and what are the key solutions, in your opinion?
Yeah, thank you, Asif. And I think for wonderful opportunity, I am really thankful for highlighting CME India also. I would like to give my pranam to Dr. B.B. Thakur sir. He is my guru, my mentor. So without him, we cannot do anything here. So that's true. So this is a very complex question which you have put here, that what we are going to do in the ward management, elderly patients going for suppose a knee replacement surgery or any other surgery. So this is definitely a complex intersection of aging physiology that we must take care of. In diabetes, there is multi-morbidity, and many peri-operative risks are there. So is this management tough or easy? In truth, it can be both. So I will say that it is easy also, it is very tough also. So if you do not anticipate challenges, but relatively easy if you have robust protocols and if you follow a simple multidisciplinary approach. So first let me tackle why is this patient population so challenging? In elderly there are lots of multiple comorbidities, and here the problem starts. Our president was telling about the EGFR, CKD. So diabetes rarely ex- exist alone. So I have not seen that one patient only coming with diabetes. But he have some CKD, some ischemic heart disease, some cognitive decline, also frailty. So these are the few problems. So a diabetic patient, suppose with CKD stage 3, undergoing this total replacement of knee will require definitely the adjusted drug dosing and fluid management. So how to tackle the altered physiology in aging, that is very important, because you have got the reduced renal and hepatic clearance. You have to take care of that. So that will affect insulin. That will affect the whole OHA which you are using, antibiotics and analgesics. Even there I have seen lots of patients having sarcopenia and malnutrition in India. I think, I don't know in your part, but we have lots of issues with the sarcopenia and the malnutrition. So that is going to for the poor wound healing and also the altered glucose metabolism. So what we are going to do? So when you do a surgery, a big surgery, itself triggers a catabolic stress response. So that will lead to hyperglycemia. And patient is not taking the proper oral intake, Also, the post-operative data increases the risk of hypoglycemia and if insulin or medications, as Dr. Vijay Viswanathan also highlighted. So, also post-operative, I told about the delayed wound healing, or could be some increased risk of delirium, and due to we are basically in India, with lots of polypharmacies being given and lots of metabolic rearrangements occurs. So again, when you do a immobilization in such patients, definitely the risk of thromboembolism is also to be taken care of. So last part I will tell you how to do we approach when it becomes so easy. So what we are going to do? So first thing that I will say that optimize before you operate. This would be the mantra. Assess the glycemic control, HbA1c target, beautifully that our Vijay Viswanathan told to keep something around 7.5 to less than 8%. But remember, avoid surgery if it is not controlled and screen the comorbidities to adjust the oral drugs with the CKD, with CVD, and you also do a nutritional assessment. Then comes the perioperative glycemic management. So current ADA and Endocrine Society recommendations that we are keeping blood sugar in between the 140 to 180 milligram per DL. This is the goal. Insulin is the drug of choice during perioperative period. What is happening these days is the most of even because in India the dapagliflozin and empagliflozin, the SGLT2 inhibitors have become so cheap that even at the periphery people are using it without knowing what it can do and what it cannot do. So this is a big challenge is happening that we have lots of euglycemic diabetic ketoacidosis we are facing in India. So this point we are going to discuss in many conferences how to tackle this euglycemic ketoacidosis with the SGLT2 inhibitors. Sulfonylurea definitely should be avoided, and post-operative care should be very, very specialized with proper nutrition and mobilization. Then we have to regular BP, blood glucose checks, you do the electrolytes, renal function, other things, and also the wound care vigilance and pain control also needs a bit care. Then the multidisciplinary is the key, and I will end here that we have got many insulin sliding scales, clear perioperative diabetes management algorithms are there, reduce the variability and improve the outcomes. So concluding my discussion here that the elderly diabetic patients undergoing the perioperative care, for example, you told about the knee surgery, are definitely indeed a complex and can pose significant challenges, perioperative vigilance. So therefore it is tough definitely if you are causal, but easy if you are very, very systemic the way I told you. So key lies that you anticipate the challenges, protocol, you follow the protocols, and you individualize the management of every patient. So definitely in complex perioperative care, what appears to be tough is often just unprepared. Preparation, if you prepare it, it becomes manageable. Thank you very, very much for this wonderful opportunity. Thank you.
Oh, thank you, Dr. Singh. That's I think that's a very, very interesting perspective, which I had to go through personally. And the reason why I brought this up, I think we've got 2 minutes to summarize, I guess, that I had this experience of my own in my own family where my mom had to undergo knee surgery. I made a 5-minute journey for a 5-minute appointment with an orthopedic surgeon to see if she could be operated upon in her late 70s. He said I wouldn't touch her until her HbA1c is less than 7.5. So we worked on it for 6 months with CGM. She got into the hospital, and then there was a complete disconnect between the orthopedic team and the medical team. Effectively, I became the middleman in between, and they had to accept me as part of the team because had she not been on CGM, she had the surgery, she went into hypos recurrently in the intensive care. When she came to the room, she was going super hyper, almost approaching DKA levels. And there was, at every level, there was an issue in terms of insulin dose, under prescription, and then someone writing, someone authorizing, taking about 2 hours. So all that brought me to think that let's discuss this today and see what people think about it. And as you rightly pointed out, that it needs that considered approach where a plan has to be made beforehand, who will do what, and how would the patient be managed properly whereas the orthopedic surgeon was most worried about the infection right from the very outset of his outpatient clinic. So I think this what perhaps I wanted to personal perspective. So that brings us nicely, if we don't have anyone else on the panel who is in the program, to the end of formally to the end of the whole summit very promptly at 12:59 hours. And I would request now Professor D.P. Singh, HOD Respiratory Medicine, having so many other API designations in Bihar, a very kind colleague, and who's always very active, runs CMEs almost every day, every week. I don't know, perhaps every day, literally, for a group of doctors and students. So, Professor Singh, it's all yours to summarize the whole summit, and then we'll have a feedback and certificate session. Thank you.
Yeah, Dr. DP Singh, I think he's unmute. Yeah.
Go ahead, sir.
Thank you, Dr. Ashish, for inviting me in this concluding session. Although we listen to this problem of hold, we are listening every year. Last year also, we had got the grand program of this hold. Honorable experts from UK and India and Bihar and Jharkhand, our friends are here. And as we conclude the whole summit, focusing on this epidemic of this cardiometabolic risk like hypertension, obesity, dyslipidemia, and diabetes. And as the time grows, that we are talking about the incidence of hypertension, incidence of diabetes, especially this obesity, they are increasing by leaps and bounds. Although the research is going on, we have got so far as hypertension, India is facing this epidemic. More than 30 crores people suffering from hypertension. And the treatment and this control of hypertension is very, very poor, maybe 7% in this urban people and 11% or this like that. And obesity, and that is also in the epidemic. And how to take it? They are this preventive aspect that is very much important. Drugs are semaglutides are here. Many others are coming in the office. This obesity, but unless we prevent this epidemic, the discussion should be there, and there should be the steps should be taken by the public, by the awareness that how to tackle. We should go to the schools where the obesity aspects of treatments we have discussed. Diabetes this epidemic is increasing by the leaps and bounds. Drugs are coming. We are talking about the continuous glucose monitoring. Control is there. Yes, we should be less than 7.5, less than 7, maybe less than that. But how much people, how much persons we are able to control. Number of diabetologists are increasing. So that is the problem. Diabetes capital is here, India is there. So how to tackle that issue, that patients, everybody taking the drugs, they are controlled, and that is the aspect that we have to see. The dyslipidemia is very, very common in India. You know that reversible risk factors, India is top most list is HDL cholesterol, or this talking about the LDLs, that is increasing. The way of this public awareness that we have to go, physicians should go. We have to aware the people about these aspects of hold, the hypertension, diabetes, and this preventive aspect we have to take care of. We have in the treatment also, we have to take care of. There are many steps we have to, that we are falling short of it. So to sum up that, what we can say, that is one of the saying that this is also called, if you want to beat this whole, this is whole represent this diabetes, hypertension, and obesity and lipidemia. But we have to do the Bhangra. And Bhangra again, last year also we talked about this. The B stands for behavioral modification. H stands for stress management. A stands for active lifestyles and exercise. N stands for nutrition. Glucose monitoring again is very, very important. That should be patient-centric. We have, you know that this is the age of personalized treatment. Every diabetic patient needs the personalized care, and we have to control that glucose targets, and we have to do that. And then the pharmacotherapy, we have got that. Risk reduction is very, very important in all these. These are the multiple approach, multicentric approach should be there. And this abstinence of smoking and alcohol, that's there. So all this Bhangra is there. That is the cultural aspect that India is rich in cultural. So we should also tackle this whole the epidemic with the cultural as well as pharmacological and scientific. That is what I have to say. Thank you.
Ashish, just a query.
Thank you very much. I think with that, we would formally come to the end of this session. And I have one little, I forgot to have one little formality, was to get my panelists commended. So could I request Dr. Anil Kumar to commend my sincere apologies.
I thought that was deliberate. Thank you.
Ashish, just a query to all the panelists.
For the registered delegates who have attended the whole summit and are in the registered delegates group, there is a link already shared for feedback. The certificate can be downloaded right now if you want a UK CPD on the screen, and you can download your certificate instantly. You have a physical certificate by the Bihar Council of Medical Registration, but wait for the QR code to be displayed. Otherwise, you won't be able to get it unless you are here. This is not going to be sent via email for the purposes of unauthorized use. So I'm going to show this in the next few minutes once we finish it. So yes.
Just a query to all the faculty.
Yes.
So friends, we have discussed a lot, starting from hypertension, obesity, diabetes, dyslipidemia. We have become wiser. We have wizened yourself. Let me tell you that our Hidden Foundation is doing a lot of commendable job by distributing not less than 10,000-20,000 booklets, which consists of all what we have discussed in this meeting. By educating ourselves, are we going to crack the problem? Or we need to go to the public at large? Is it not necessary for all the associations to hold such meetings in different areas of the country so that the people at large are? And don't you agree that we all should strive hard to put a topic in the medical curriculum very effectively, very as early as possible, like lifestyle medicine? Is it not necessary that we should follow ourselves lifestyle medicine and avoid sumptuous foods in different meetings that the doctors are doing? Saturday night, I had a party in one of the Radhe Radhe hotel. Radhe Radhe means Radha, I mean wife of Krishna. I was sitting inside and there was so much huge crowd in the hall. Everybody was eating whatnot. So my suggestion is, okay, fine. Hypertension has got a triple paradox, easy to diagnose, easy to investigate, easy to treat, drugs are available 20%. Diabetes, we have pre-diabetes. Are we emphasizing people over pre-diabetic? None of the doctors, I bet, sir. I always inquire from my patients, have you been educated about pre-diabetes? No. None of the doctors have taken the family history of the patients. So friends, we need to think over that, especially to Vijay Viswanathan, Dr. N.K. Singh, that look into that aspect. You had a very good talk last time in possibly in one of the meetings about pre-diabetes. But are we really taking care of the pre-diabetes? So I will conclude, we are not doing what we should do. We are not going to the public at large. However, nowadays there is an organization, NCD. The doctors are posted, but people are not being educated. So friends, it has been a wonderful day. I have learned a lot, but still I make a query. Are we doing justice to our people at large? Thank you. Vijay, you like to comment, Vijay?
Thank you, sir. We will
Certainly, sir.
this session with best wishes from all of you from India and people present here physically in England. We will just say goodbye to each other for now, and we'll carry on with the lunch which is being served as we speak. Before that, I have to issue certificates from here. So thank you for each one of you. Pranam, and please have a good evening, everyone. I will post a link to all of you at your registered email addresses for your feedback, and you will be issued with a digital certificate, what has been issued in paper form here, as per the BCMR accreditation. Thank you so much. We will end this meeting now promptly at, well, we're 4 minutes early. Thank you so much, but time remaining for some certificates for our delegates here. Thank you.
Dr. Vijay wants to make some comment. I see Dr. Vijay will take 1 to 2 minutes to make a comment.
I think we are running late. The lunch has started. So, Dr. Vijay, say something, sir, quickly.
Or India,
30 seconds.
Yeah, please go ahead, sir.
I think Dr. N.K. Singh and Dr. Anil Virmani are poised to take over RSSDI.
Yeah.
And they should take up this issue of pre-diabetes in a big way. And it's my hope. And we have more pre-diabetes in India than diabetes. So we have Dr. B.B. Thakur sir's good advice. And RSSDI is in safe hands, in the hands of Anil Virmani and N.K. Singh sir. And we should take it up. Pre-diabetes is a big issue.
Yes, sir.
Everybody should know about pre-diabetes, and everybody should talk about pre-diabetes.
Very true. Very true.
Very true, sir. Excellent, sir. Excellent wisdom, sir.
I'll just make a small comment as a moderator, if you allow me at the end, very end. As a cardiologist, we don't believe in pre-diabetes at all, because the 10-year risk or MACE or cardiovascular risk of major events or macrovascular events is exactly the same in someone with, under inverted commas, pre-diabetes versus diabetes. That was our theme of Hold On last year, where we said, shall we get rid of the term? Or it's health economy related. It's just politics. It's either diabetes or no diabetes. For me, for us, anything 39 and above is diabetes, to be honest, as per ADA criteria. Pre-diabetes, HbA1c criteria as per NICE 42. Yes, pre-diabetes by them, for them, but for us, it's diabetes. So we will go as aggressive as possible, thinking they've already got vascular disease. Thank you very much for your time. Thank you.
Thank you.
I will meet again in our autumn World Summit. Thank you very much.
Thank you, sir. Thank you. Thank you.
Okay, namaskar.
Super.